Welcome back, everyone, and thank you so much for being on time. If you are joining us for the first time today, we have a full afternoon planned for you that includes polling, session evaluations, and a keynote session. For our webcast viewers, please remember utilizing an Ethernet connection instead of Wi-Fi, and using Google Chrome may increase your webcast streaming speed and prevent any delays. Conference materials to enhance your experience are available on the CTEO website and include the fall conference guide, presentations, and participant instructions. In addition, we have the participant survey instructions posted there, and these instructions have web links and QR codes that will take you directly to the Ask CMS Live questions and the participant experience survey and the CCB attendance survey. And with that CCB attendance survey, don't forget that needs completed by September 24th in order to get credits. So finally, again, you can go to the website to get the conference guide, presentations, and the participant survey instructions. All right, well, I said I would check back in with you guys to see how you're feeling after lunch. So please take out those cell phones or go to that webpage and tell us which emoji best represents how you are feeling after lunch. Is it really happy, a little bit sick, I guess, sleepy, or angry? Did things not go well? So tell us how you're feeling now. Looks like everyone had a pretty good lunch because nobody's green and a lot of people are sleepy. Awesome. Well, it's time to wake up because we have our next session that features a panel of speakers who will provide participants with additional direction for appropriately classifying requests for grievances, organization, and coverage determinations and appeals. These speakers will present examples of best practices for classification from Blue Cross Blue Shield of Tennessee. I am happy to introduce to you from the Division of Appeals Policy, Medicare Enrollment and Appeals Group, Stacy Page and Coretta Edmondson, and from Blue Cross Blue Shield of Tennessee, Destiny Gordon and Crescent Moore.
Good afternoon. Good afternoon. Good afternoon, everyone. Is the mic? Good afternoon, everyone. Good afternoon, everyone, and thank you for joining us this session, where we will be discussing best practices for classifying grievances, coverage requests, and appeals. My name is Coretta Edmondson, and I am joined here today with my colleague Stacy Page, as well as Destiny Gordon and Crescent Moore, both from Blue Cross Blue Shield of Tennessee, who will be discussing best practices that they have implemented for appropriate classification. So today's objective is to clarify the difference between grievances, coverage organization determination, appeals, as well as inquiries. We will also be talking about classifying co-payment requests as well as investigating quality of care grievances. So due to the number of inquiries that we continue to receive in the Part C and Part D appeals mailbox, as well as the concerns that are brought to our attention during audits, we feel as though it's important to continue to have discussions or conversations around appropriate classification. So what is the difference between a grievance, a coverage or organization determination, appeal, or an inquiry? We will look at key terms to keep in mind when classifying these types of cases. We will first start with grievances. So as we know, a grievance is an expression of dissatisfaction with any aspect of plan operations or activities, or the way the plan or a delegated entity has provided Part C services or Part D benefits, regardless of whether remedial action is requested or is in fact taken. So the key term here is dissatisfaction. So is the enrollee dissatisfied with the service or benefit that they have received? Do they have a complaint against a particular pharmacy or a provider? Are they unhappy with the plan's operations? If that's the case, these would be considered a grievance. Keeping in mind, though, sometimes grievances may come in, but they also may include either a coverage request or an appeal. For example, if a Benny wanted services or Part D benefit, and they had to wait too long for the services or to receive the drug, and they decided to go out of network, that would encompass one or more cases that needed to be reviewed, so in the appropriate category. So you would have to investigate, classify appropriately, and issue the appropriate determination within the required timeframes. Next, we'll talk about coverage or organization determination. So that would be any decision made by or on behalf of a plan regarding payment or benefits to which an enrollee believes he or she is entitled. So the key term here would be decision. So you're addressing a request for a coverage or an organization determination that involves, again, a decision, and these decisions are always related to either a payment or provision of a service or benefit. Sometimes coverage or organization determination requests are not evident at first because the enrollees may first inquire about the coverage or benefit before stating they actually would like to receive it. Excuse me. The next slide discusses appeals. Appeal is a review process that is initiated following a dispute of an adverse coverage or organization determination. And in this case, the key term is dispute. So the plan has issued a denial with appeal rights. So two things you need to keep in mind would be, or as apparent, is there is a request of appeal that's being made, and there is a mention of either a coverage organization determination or the initial request has in fact been denied. Again, the key is to identify whether or not there is a dispute over the plan's decision, because essentially the enrollee or the representative is unhappy with the decision that has been issued. I apologize. The next slide is inquiry. An inquiry is a general question about benefits or coverage. Again, it's just a general question. There is no indication of a request for coverage, and there is no expressing dissatisfaction relating to non-coverage. Now, that does not mean that every time an inquiry comes in that there may not be ultimately a grievance or a request for coverage. So after you address the questions that are being asked, you should probe the representative to find out if there are any additional questions or if the beneficiary ultimately would like to request coverage. So at this time, I'm going to turn it over to Stacy Page, who will discuss copayment and quality of care concerns.
Thank you, Coretta. As she had previously mentioned, we do get questions frequently about classification, which does include when a copay, a request or a complaint about a copay is considered a grievance or an appeal. Excellent. So first we'll talk about when, next slide please. First, we'll talk about when a copayment or a call about a copayment is considered an appeal. So when an enrollee believes that the plan has required them to pay an amount that should be paid for by the plan, we would consider this an appeal. A couple of examples would include if an enrollee says, well, the copay charged to me is higher than it should be, or I was charged and I shouldn't have been. I don't have a copay for this service. As mentioned before, an appeal involves a dispute that an enrollee has related to a coverage or organization determination that they believe the plan should have covered. So appeals related to copays will follow the same guidelines. That enrollee believes that the plan should have covered or paid for that copay. So the next is when they are considered grievances. So a grievance is a general dissatisfaction of a copayment amount or request to waive a copay to make up for a poor experience. So examples here would be the office staff was rude, so I don't think I should have to pay my copay. Or the doctor only spent 10 minutes with me and I expected more time. I shouldn't have to pay this copay. So if the complaint about a copay is not related to a dispute regarding the decision of an organization or coverage determination, or not a dispute about the amount of the copay, it would typically be a grievance. We do want to remind everyone, though, that the final classification of a call or a concern is dependent upon the facts and circumstances of each case. Next slide, please. So we've also received questions about classification and investigation of quality of care grievances. So we'll take an example and we'll have a polling question with it. So a scenario is a member contacts their plan and states that they believe they were misdiagnosed by their doctor, and as a result, they were sick longer than they should have been. The customer service representative classifies this as a quality of care grievance. A medical professional with the plan investigates the complaint and determines that the member was correctly diagnosed and received appropriate treatment. So the responses for this polling question, what the next step should be are A, you would close the case. The investigation is complete and no further action is needed. B, you would reclassify this as a regular grievance. C, you would send notice to the enrollee that the quality of care investigation is complete and inform them of their right to file a grievance with the QIO or Quality Improvement Organization. Or D, close the case and tell the enrollee the status if they decide to call back. So most of the responses you all provided are correct. The answer is C. You would send the notice to the enrollee that the investigation is complete and inform them of their right to file a grievance with the Quality Improvement Organization. So we just want to kind of go over again what is considered a quality of care grievance. Next slide, please. What happened? So quality of care grievance is a type of grievance that suggests services provided by a plan or a provider do not meet professionally recognized standards of health care. Examples of quality of care grievances could include any instances where an enrollee infers or states that they were misdiagnosed, the treatment was not appropriate, or the care that was provided adversely impacted or had the potential to adversely impact their health or well-being. And quality of care grievances may be reviewed by medical professionals. So now that we've gone over the difference between grievances, organization coverage determination, appeals, and inquiries, and touched a little bit on classifying concerns about co-payments and quality of care grievances, I'd like to turn it over to Destiny to go over some best practices for classification.
Thank you, Stacy. Good afternoon, everyone. There is so much that we could discuss around this topic, but our discussion highlights for today include our customer service being centralized, having cross-functional training and ongoing education, root cause analysis processes, Part C and D specifics, we will cover some things on that, and then some references and resource information. One thing we think that has helped us as a plan is we have one stop for members to get or be transferred for help. This is by having a centralized call unit for members to get assistance. We train to assist and triage member inquiries based on the member's needs or requests. We ask probing questions as members don't always know what to ask. By focusing on asking probing questions and listening to the member perception of their needs and assisting based on that is important for appropriate classifications. We also don't give members homework, especially related to coverage decisions and complaints. We're right here is our message to our members. This includes getting them help through understanding the processes with the health plan or their providers. Be familiar with the guidance and prep the training for your audience is also something that we have implemented from a training and education standpoint. All of our staff are trained on classifications and routing processes. It is important to understand the need to really listen to and review requests so that we do not misinterpret what the member is needing from us as a plan. We also educate on the risk of not classifying correctly. That could include issues with member access to care and audit findings. Also, we have our staff educated on identifying keywords in discussions with callers. For example, need versus not satisfied with the decision on a service, or dislike versus disagree with the copay. We also like to make sure that our staff understands that we can avoid misclassifications when everyone understands the guidance by being able to identify coverage requests, appeals, grievances, or even if there are multiples present. This is important because depending on what a member says to us as a plan, that may drive or that will drive how a particular case could be classified. For example, if a member calls into customer service expressing the desire to file an appeal, we know that an org determ or coverage decision should have taken place already. Also with training and education, we do ongoing scenario-based training and coaching referrals. So what that means is with scenario-based training, we let that drive our improvement strategies with education. We feel like real-life examples are more impactful for the staff to understand the appropriate classifications. We also train more than once to keep the requirements fresh. Quality reviews, one thing that we've implemented is putting classifications as something to be checked for as part of this process. It connects to performance and it also lessens errors for misclassifications. We also require our staff to, of course, take the CMS, CDAG, and ODAG training. And again, we take each scenario case by case for proper classification. And we have a motto that we have implemented in our customer service and grievance area where it is when in doubt, route. And what that means is we would rather take a look at it and appropriate classify it than to not have looked at it at all. Some best practices for Part C coverage requests that we've implemented include our staff being trained to listen to the member perception of needs. That is by, again, listening to those key words and asking probing questions and assist in appropriate classifications. We also follow up for additional information needed for requests. This includes calls for clarification if a request is unclear. And I cannot stress enough the importance of listening to the member perception. Remembering it does not matter what we feel as far as something being covered or reviewed. If a member says they want or feel that they need a service, regardless of what the outcome may be, we have a responsibility to have it reviewed. We will now have a polling question, and that is, a member calls customer service concerned that he received a denial letter for a requested dental surgery. He is not pleased with the decision as he pays his premiums and does not use his benefits often. He wants this reviewed for coverage. He says he is having to blend fruits and vegetables because it pains him to chew and eat. He feels a NutriBlender should be covered by the plan as it is his only method of eating. How would you classify this case? A, as a coverage decision, a B, an appeal and a grievance, or C, a grievance, appeal, and a coverage decision? We still have a few responses coming in, but it looks like most people selected the correct answer, and that is C. It is C because a coverage decision is present because the member noted that he is having to blend fruits and vegetables because it pains him to chew and eat, and he feels that a NutriBlender should be covered by the plan, and it is his only method of eating. It's also an appeal because he is not pleased with the decision and he wants this reviewed for coverage. And lastly, it's a grievance also because he is not pleased with the decision as he pays his premiums and does not use his benefits often. So again, focusing on the member perception and listening for those key words, not that the request includes a NutriBlender. We may have our thoughts on the outcome of this request, but in this example, the member noted dissatisfaction and a need for something. Some best practices implemented for appeals include having an intake staff added. And I personally feel this has been a golden ticket for us as a plan. Having that classification touch point happen efficiently has been a plus. This helps us catch potential misclassifications and allows timely rerouting of the request. Intake staff have processes to immediately identify cases for appropriate classification, especially urgent or expedited, although the request may not say that it is expedited. Also knowing keywords for expedited identification, things like in urgent need of a service due to pain or expedited from a medical director. Again, we also train to understand the importance of member access to care. The intake team also checks all method of entry of requests throughout the day, including phone call inquiry, referrals, email boxes, snail mail boxes. Any method that we can receive a request is checked throughout the day. We also work closely with our utilization management teams as well as our medical directors when it comes to appeals classifications. Some grievance best practices that we've implemented. We have a centralized unit for Part C and Part D grievances, again with intake processes for clarification. So as I noted earlier, customer service when it comes to phone calls is our initial stop for help. Our grievance intake team reviews those requests and looks at them for appropriate classification and assignment. And then our grievance analysts actually research to confirm and or provide a resolution. This also includes looking at inquiry notes, telephone call reviews, as well as follow-up when needed. This also further supports appropriate classifications. So having one team handle both C and D grievances has been a best practice. It has also minimized errors in classifications and turnaround times, and it allows us to quickly identify potential misroutes of coverage requests and get them transferred timely. This also gives us the ability for timely reviews and tracking and trending of grievances. If our team notices a trend with a specific issue or department, we review and communicate early on, and we then work together with the appropriate teams on process improvements where we can. We will now hear from Crescent on some Part D specifics.
Thank you, Destiny. Good afternoon, everyone. I'm going to speak about best practices associated with classifying Part D coverage determinations and appeals. As Destiny just mentioned, at Blue Cross, we have one centralized grievance team that handles both Part C and Part D grievances. Previously, our Part D grievances were delegated out to our PBM, and what we found with that is that it did slow down the process time for resolving those grievances because there was an additional vendor or person that we had to reach out to either get the recorded calls sent back over to us or a transcript of those calls, and it really just slowed down our ability to timely process our grievances in a timely manner. Since we've been able to move our Part D grievances in-house and have them sit under a centralized team, it has allowed for better coordination of efforts related to both member requests and CMS requests. Additionally, our Part D CDA team has worked with our grievance team to establish identification and routing processes to ensure that grievances are handled in a timely manner. As Destiny mentioned, our customer service does serve as that initial point of contact for our members. However, from a coverage determination and appeals team, we often have additional contact with our member, especially when we're making those outbound notification calls. And that is another point in which we can identify a grievance, and often do identify, especially when we're having to call to let a member know that a request has been denied. And so again, establishing a routing process and identification process allows us to pick up on those grievances and get those routed over to the grievance team in a timely manner. Additionally, our coverage determination and appeals team has given access to our grievance team to both our documentation system and access to our recorded calls. And I really feel like this really enables our grievance team to be able to process things, again, in a much more timely fashion. They are able to log into our system. They have read-only access so that they're able to see where we are with a particular coverage request or an appeal. If a case has already been decisioned and closed, they're able to pull any documentation that they need. And then by allowing them to have access, immediate access to our recorded calls, they're able to go ahead and expeditiously resolve cases. As we all know, training is one of the most important aspects in ensuring that your team can appropriately classify appeals and coverage requests. At Blue Cross, we train up on hire and annually, and we utilize resources such as the Medicare Learning Network, as well as internal resources that we have built ourselves. Additionally, we've worked with the grievance team to establish a training that's specific to Part D coverage determinations and appeals so that the CDA team is appropriately trained on how to correctly classify any request that they receive. We utilize countermeasure tracking to identify trends and potential misclassifications so that we can retrain and educate in a timely manner. And then finally, we utilize job aids. So we know that there's a lot of information around the coverage determination and appeals process, and for our teams that are working the cases, it can sometimes be confusing. So we utilize job aids to take the information that we receive and put these into easy to understand material that they can have at their desk and be easily accessible to them. Quality assurance efforts are key to ensuring that cases are being categorized appropriately. At Blue Cross, we perform a monthly quality review of both primary and level 1 appeal cases, and we utilize a random sampling methodology to get a good sampling of not only cases, but also of reviewers of those cases. So for instance, we want to make sure that we are not just pulling the same type of cases, so that we're not only pulling prior authorization or only pulling exception cases. We also want to make sure that we're getting a good sampling across the members of our team so that everyone is represented in that sample. Any issues identified during the review process that are team member specific are immediately addressed with the team member so that we can again quickly re-educate and retrain on the proper classification and processing of cases. And then any process and system issues are addressed in a bi-weekly Center of Excellence meeting attended by our coverage determination and appeals management, our operations team members, and our compliance team members. This quality assurance process that we've put in place has really been something that has allowed us to improve the quality of the cases that we are processing because we look for everything from, was the case decided timely? Did we send out the correct letters? Did our letters include their appeal rights when they should? Also, we look at things, was a prior authorization case correctly identified as a prior authorization case? So things of that nature that allow us to quickly pick up on any issues that our team members may be facing. I always encourage plans to utilize the capabilities of your systems to their fullest. To that end, our system allows us to have primary and appeal cases linked, as well as serves as a centralized document repository for all communications associated with a member's case. Not only does this make it easy for the grievance team to go in and look at all of the history associated with a member's particular case, but it also allows us as a CDA team to be able to quickly identify what type of case needs to be built next. As plans, we are used to configuring our systems for turnaround times. So we know we have them configured so that we meet those 24 and 72 hours for primary cases, and that 72 hours and 7-day turnaround time for those level 1 appeal cases. However, we additionally have our timeframes built into our systems. For instance, if a case is still within a 60-day window to allow for a level 1 appeal, our system will allow the level 1 appeal to be built. However, let's say a request comes in on the 61st or 62nd day, our system is configured to know that we've exceeded that time frame and another primary case needs to be built. Although our team members are educated on how to appropriately identify cases and whether a primary or a level 1 appeal case should be built, this is an extra check to ensure that cases are appropriately classified. Finally, I'd like to close our presentation by reviewing various resources and references plans can use to aid in correctly classifying requests. It is important to ensure that you have good reference materials and a quality system at your disposal. Of note, the most obvious set of resources that we have are those that are produced by CMS. However, internally, we've built an online help which is accessible to all people in our organization. And you can go in and get instructions on how to do various processes within various steps within the processes. So if you needed to know how to route a grievance case, then it has information there. Additionally, establishing contacts and ongoing communication in all departments for escalations is important to ensure timely resolution of grievances, but it also allows for it to go the other way. So if within a grievance, the identification of a coverage request happens, then the information can flow quickly back the other way. Those cases can be built and decisioned in a timely manner. At Blue Cross, we have a compliance team member embedded as a partner within each of our teams. This compliance partner performs activities such as universe reviews, quality assurance activities, and serves as an additional Medicare resource for us when there are questions around any of the guidance. And finally, I cannot emphasize enough the importance of utilizing your CMS account managers. They are a valuable resource with a wealth of knowledge that often aren't utilized enough. At this time, I'd like to turn it back over to our conference moderators.
Okay, thank you to our panel. We do have some time for questions. So we're going to go ahead and open the floor up for questions. If you have a question, go ahead and step to the center of the room where the microphone and state your name and where you're from and ask your question. Okay, well, we do not have any in, oh, go ahead, I'm sorry. I didn't see you walking.
Hi there. Am I on? Yeah.
You're on.
Derek Fry with Birchfield. One thing I didn't see a lot called out here is the use of a reopening. I saw a lot of examples focused on other things, and I just wondered if you had any thoughts on when is the appropriate time to use that versus an appeal or what have you.
Thank you. Yeah, I think that we did address reopenings at the audit conference in the spring and had a few examples there, but we can definitely consider touching on that in the future or in future guidance. So thank you.
Thank you.
Yep.
Okay, thank you for that question. Any other questions from our in-house participants? Okay, we did receive some questions from the webcast participants. One of them that we're going to go ahead and ask is, if a member calls for any reason related to a drug question, do we always need to open or start a coverage determination or redetermination in cases without any new clinical information? And if for all received grievances where a drug is related, do we need to open a coverage determination or redetermination?
Thank you for that question. So we always say that each case really should be handled on a case-by-case basis. So for example, if the plan sponsor were to process a coverage or redetermination, they would handle it in that case if, for example, the enrollee indicates they want a drug, or they ran out of a particular drug, or they were at the pharmacy and their request was denied and they called the plan and ultimately they're asking for coverage of that drug. Or it could also be they're questioning the exclusion or non-coverage of a drug. So again, it goes back to reviewing on a case-by-case basis. As far as grievances are concerned, you really need to look at the letter and what the specific request is. And if those are very similar circumstances that I just answered, then yes, those would be handled as either a coverage determination or a redetermination, depending on the status of or what part of the process that question came in.
Okay, thank you. And I'll see, does anyone, before we go on to more webcast participant questions, are there any other in-house questions? Okay. So from another webcast participant, if a plan receives a request from a member to change their PCP to another in-work PCP, is this considered an organization determination? What if the member requested to change their PCP to an in-network specialist provider? Is this considered an organization determination?
Neither one of the scenarios that were just described would be considered an organization determination. The plan would follow whatever policies and procedures that they have in place when it relates to requests to change primary care providers.
Okay, thank you. And another question that we received, would CMS consider providing call scripting for call centers to use when handling calls that could potentially be a complaint? This would help plans with consistency and remove the subjectivity that call centers are struggling with.
So no, at this time we do not have any plans to provide any type of call scripting. So each call, as Coretta and I had previously said, should be handled on a case-by-case basis according to each plan's policies and procedures that is in accordance with the guidance in Chapter 13 and Chapter 18. Thank you.
Thank you. Okay. And I'm going to go ahead and go with another question. And this one's a bit longer. And this person says, I'm wondering if you could address reclassification of grievances after the investigation is completed. For example, if the initial call is classified as a quality of care issue, and upon investigation it is deemed as not a quality of care concern, should that no longer be considered quality of care simply because the plan agrees with the treatment regimen of the provider? And I have seen conflicting opinions on this, and I'm wondering if it is reclassified and the beneficiary isn't offered the opportunity to have a, I believe this is a QIO review. Is that the intention of the regs?
Okay, so as discussed in the presentation, a quality of care grievance should not be reclassified after an investigation is complete. So once an investigation is completed, even if it's not determined that there was an issue, kind of in the scenario where we said that the medical professional did not believe that the enrollee was misdiagnosed, even though that investigation came up with that conclusion, it would still be considered a quality of care grievance, and the enrollee would be issued QIO rights.
Okay, thank you. And I do see we have some people who would like to ask some questions. As a reminder, please state your name and where you're from and your question.
Hi, I'm Heidi Harmon from Gorman Health Group, and I'm wondering when we might expect an update to Chapter 13?
So we are continuing to work on updates to Chapter 13 as well as 18. We're going through final stages at this point. We don't have an exact date for you, but you should be receiving something to review shortly.
Okay. Thank you. Next question, please.
Hi, I'm Nita Firestone from Senior Health Services, and as you know, it takes a lot more to handle a grievance or appeal than it would for an inquiry that's coming into your call center. And I'm wondering if our friends at the Tennessee Plan could talk at all about what staffing impacts they might have had as they've gotten to a best practice state.
So as far as staffing for specific to appeals and grievances?
Yes.
Okay. So we have really grown in our appeals and grievances area over the years. So we have one team that actually processes Part C appeals and Part C and D grievances together. And as far as how the structure is laid out, we have the intake associates, and we have a few appeals and grievance analysts that actually process the day-to-day cases, as well as a nurse that is attentive to the clinical cases. And then we also have business analysts that handle the day-to-day reporting, the data validation reporting, anything related to universes and audit preparation. And then we have, of course, myself that leads the team.
Okay. So it's grown from like...
So you have to look at it from the perspective of membership growth. So as membership has grown, we have grown.
Okay. Thank you.
Okay. Thank you for that question. Any other questions from our in-house audience? Okay, so with that being said, I want to thank our panel for their clarification of CMS guidance and sharing your best practices. Okay, if you would like to evaluate this session, please go ahead and take out your phones to text your response, or go to the Poll EV link on your iPad, tablets, or computer, and enter A in response to the question, "I would like to evaluate the session," and send your response. When you receive the link, click on it and follow the instructions. Next slide. Our next panel consists of CM directors who will discuss CMS operations and how decisions are made. It is my pleasure to introduce to you the Center for Medicare directors, Catherine Coleman, Amy Larrick, Jerry McCaughey, John Scott, and Rebecca Paul.
Good afternoon. Thank you all for joining us this afternoon. And excited to give you a minute with the team up here, talk a little bit about a little more of an insider view of what we do at CMS and the Center for Medicare and how we are organized and structured. I think they say about 70% of the workforce is an ISTJ and that Myers-Briggs thing. So as you can imagine, whenever we say it's a pleasure to be here, just, you can look at us a little like, really? Because that I doesn't stand for interesting or incredible. It actually stands for introverted. Some of us think incredibly introverted, and some of us might say incredible but introverted. So it may be incredible that we're all sitting up here talking with you twice in 1 year, I think. So first, as many of you probably know, our center is headed up by a gentleman by the name of Dimitris Kazoukas. He is the Principal Deputy Administrator and Director of the Center for Medicare. You'll be hearing from Demetrius after the break. He serves as our leader on the C&D side, as well as the original Medicare side of the center. So he has a huge job and a huge portfolio, and we do our best to help him with that every day. He's serves as the lead and the focal point for the formation, coordination, integration, implementation, and evaluation of the Medicare program at large, including its operations, and he is the agency's lead for the management and oversight, the budget, the performance of Medicare Advantage and prescription drug plans, as well as all our Medicare fee-for-service providers and contractors, such as health plans like many of you and Part D sponsors, as well as the Medicare administrative contractors on the fee-for-service side. So directly beneath Demetrius is our collective and immediate boss, Sherry Rice. And Sherry is the Deputy Center Director for the Part C and D center half of the Center for Medicare. So she directly manages all of us at the table and works with us to implement the Medicare Advantage and Part D programs. So each of us at the table today represents one of the 5 blue boxes up on the screen. And you'll hear a little bit about each one of those in a little more detail in just a minute. Sherry has a counterpart on that fee-for-service side of the house in the center named Liz Richter, and the two of them both report up to Demetrius. So somehow I drew the short straw, and I get to go first. So I'll kick off the presentation and describe a little bit about what I regard as the best group within the center, which is mine. So we are called the Medicare Drug and Health Plan Contract Administration Group, but we do far more than I think that title probably provides, and I think some of us question why we're called that on most days anyway. But nevertheless, we're a small and mighty bunch of folks. There's about 50 of us in all, and we're split among 4 divisions. I don't know if you can see that, but I'll describe all of those boxes. So starting on what's the left side of your slide is the Division of Finance and Benefits, and that's headed up by a gentleman named Dale Summers, and his deputy is Yasmin Galvez. They are responsible for reviewing your plan benefit packages during the bid season, so over the summer months, as well as keeping track of plan financial information. So if you have bid issues or questions over the summertime, most likely someone from Dale and Yasmin's team is going to be reaching out to you and talking you through those issues. They're also responsible for setting the total beneficiary cost threshold each year, and working through those evaluations and with the Office of the Actuary. They work very closely with them. This year they had the pleasure of reviewing and approving the new supplemental benefits flexibilities that we established, the reinterpretation of uniformity, as well as the expansion of what we considered health-related services. So they're also responsible and gearing up in just a few weeks to release the annual landscape of plans, which generally gets released in the middle of this month, just before the start of the marketing period. So if we move over one more box to the right, it's the Division of Surveillance, Compliance, and Marketing. These are the ones that are responsible for developing all of the marketing requirements and the guidelines that govern the sales practices of agents and brokers on a national level, and responsible for actually getting the marketing and communications guidelines out just this morning, I believe, which is always exciting. They also update and maintain the annual notice of change and the evidence of coverage documents, which sounds very mundane and boring, but is a huge undertaking each year to make sure that we've fully accounted for all of the changes in benefits and requirements that you all are responsible for. They work closely with the account managers in our Consortium for Medicare Health Plans operations all across the country, your account managers, in ensuring that you all understand and are abiding by the Part C rules, and ensuring that there's consistency across the country in those decisions around compliance from plan to plan throughout the year. And they also assist with educating our marketing reviewers across the country, making sure they understand the rules and approval process for marketing materials. And they work closely with folks in the Medicare Drug Benefit Group with the annual past performance analysis, helping with the data and analysis on the Part C side of the elements of that analysis. Third on the chart here is the Division of Policy Analysis and Planning. It's headed up by a gentleman by the name of Mike DeBella. Oh, I think I forgot to say who leads surveillance and compliance. That's Tim Rowe, who's the director, and Erica Sontag is his deputy. So for policy analysis and planning, it's headed up by a gentleman by the name of Mike DeBella. Some of you might be familiar with Mike when he was in our audit and enforcement group. He's now joined our group and is leading the policy development for MA, which includes writing regulations and guidance documents, the manuals, responding to inquiries from the plans about policy questions they might have on the Part C side, or stakeholders or Congress. He's assisted by his deputy is acting Deputy Heather Kilborn. If you have a question about Part C policy, you probably submit it through a mailbox that goes directly to Mike and his team for response. So they have a huge workload and a huge breadth and depth of responsibility. Finally, the last box on the far right there is the Division of Medicare Advantage Operations, which is led by Kathy Baldwin. Kathy's division oversees all of the processes and work that goes behind the Medicare Advantage application process each year. I'm sure many of you have experience working with Kathy's team. She's assisted quite a bit by the folks in the regional offices in a collaborative process to review those applications. I know we undertook a new process this year with the network reviews, and Kathy's team was responsible for designing and implementing that new way. Right now, they're wrapping up that first year of the 1/3 reviews of existing networks and all of those who applied for service area expansion this year. We're really excited to implement the new process, and we look forward to hearing your feedback about how that went and what you thought of it. Kathy's group is also responsible for processing PACE applications, ensuring that your state Medicaid agency contracts are in place for all of your D-SNP products, as well as processing changes of ownership and novations. So I think that does it for my group. I will pass the clicker over to Amy.
All right, good afternoon, everyone. My name is Amy Larrick. I'm the director of the Medicare Drug Benefit and CND Data Group. My deputy is Jennifer Shapiro. So Mudbug, as we affectionately call ourselves, has 6 divisions. We're the sister division, I would say, to Catherine's group, sister group to Catherine's group, in that we do the Part D policy and operations. And most of the time we get along like sisters. Sometimes we fight like sisters, but. And so we have 6 divisions and 93 people right now. So the Division of Benefit Purchasing and Monitoring is run by Linda Anders and Michael Newman. Linda is probably the person you generally do not want to see come up on your caller ID, because Linda's division, oops, hold on. There we go. Linda's division is in charge of compliance, Part C and D compliance. But Linda's also the person that you want to talk to if you want to keep your plan compliant. So she's very good about helping people. So if you are thinking you're doing something innovative and you want to keep yourself compliant, talk to Linda. In addition to the compliance, Linda's division also does Part D applications and contracting, and they do a lot of the Part C and D monitoring efforts. I'm not going to read every single one of these on the slide. I'm just going to kind of touch the highlights for each of the divisions. The next division is the Division of Consumer Assessment and Plan Performance. That division is run by Liz Goldstein, who to most of you, Liz Goldstein is synonymous with star ratings. Liz Goldstein's deputy is David Miranda. In addition to the star ratings, particularly the Part C star ratings, Liz's division also is responsible for survey administration, including CAPS, HOS, and the disenrollment reason surveys, and also a lot of the fee-for-service surveys as well. We conduct, oh, hold on, my screen went black, all right. And then they also do a lot of the communications research. So for the C&D side of CM, they work the most closely with the Office of Communications on communication research. So things like doing Benny testing of different letters that we are putting out models for. We work a lot on that. The Division of Clinical and Operational Performance is run by Michelle Ketchum. They do the Part D star ratings, so they work very closely with Liz's division on the star ratings. In addition to star ratings, they've been extremely busy lately because Michelle Ketchum's division is also responsible for most of the opioid work that's being done on the C&D side. I think I forgot to mention Michelle Ketchum is the division director and Alice Lee Martin is her deputy. So they run the opioid work, including all the edits that were included in the 2019 call letter and also the OMS system. In addition to that, they do the Part D data accuracy in the Plan Finder and Part D reporting requirements and NTM and all sorts of other work. The Division of Formulary and Benefit Operations is run by Brian Martin, and his deputy is Andrea Bendewald. This team is the team that reviews your Part D formulary and benefit submissions that you make every year, and also any changes that you make within the plan year. They also do a lot of analysis on Part D drug data, and they provide a lot of the clinical expertise when we're making Part D policy decisions. This division is mostly pharmacists. The Division of Plan Data is run by Lori Robinson and Anna Nunez. This division is very technical and operational. They really serve the entire side of CPC, CPC of the C&D side of CM. Most notably, what they run is the HPMS system. But they do a lot of work across all of C&D to operationalize all our amazing policy ideas that we come up with, and we always try to keep them in mind when we're making decisions. And they also work a lot across different components as well. And then finally, the Division of Part D Policy is run by Chris Bauer, and his deputy is Craig Miner. They really do exactly what they say. They do the Part D benefit policy, which includes TROOP and COB and coverage gap discount policy. They do most of the reg writing the Part D reg writing, and they do most of the Part D pieces of the call letter. Mudbug prides ourselves on our relationship that we have with our partners. We consider the plans our partners. And so I encourage you to reach out to us if you have any questions that you think we can help with. Again, we always like to hear problems before they happen instead of after. And so please feel free to reach out to me or to any of the division directors should you ever have any questions. Thank you, and I'll turn it over to Jerry.
Hey everyone, I'm Jerry Mulcahy. I've had the pleasure of working with many of you over the years, and I think anyone who knows me knows that I am not an introvert. So I don't fit the normal criteria or the demo for a federal employee. The other thing I can say is that my group, the Medicare Enrollment and Appeals Group, my title says exactly what we're responsible for, unlike the last two, which is a little bit more complicated. So I would reorganize this now if I could, because we are separated between enrollment and appeals work, basically. So we have an enrollment policy, and we have enrollment operations, which is the Division of Medicare Enrollment Coordination. And we have a Division of Appeals Policy, and we have a Division of Appeals Operation. One of the things I want to mention is that a little bit unique we sit on this side of the house, the sort of the C&D side of the house, but we're responsible for enrollment and appeals for A, B, C, and D. So in the Division of Enrollment Policy and Operations and Appeals Policy and Operation, there's A and B and C and D, and we have different teams within there. So our Division of Enrollment and Eligibility Policy, we really handle all of the manual guidance, reg writing, some of the, on the A and B side, some of the things like Medigap enrollment policy. And then in the division, I'll jump over to the right, in the Division of Medicare Enrollment Coordination, that is really the systems. That's the enrollment system, the enrollment process. Those are all the transactions that you send to CMS and all the reply reports that we send back to you. And then we have the Division of Appeals Policy, and that is, again, divided between A and B and then C and D. And so for appeals-related information, we are responsible for the manuals, any regulations, HPMS memos, guidance, any interpretation like that. And then in the Division of Appeals Operation, this is mostly the A and B side of the house, where we oversee the QUICs and provide the QUICs with all the guidance related to coverage determinations and manual instructions, monitoring. So that's mostly fee-for-service. I'm going to jump back because I'm realizing I'm not telling you who's running these divisions. So the Division of Enrollment and Eligibility Policy is Patty Helfenstein, and she's been with us for a long time, so I'm sure many of you have interacted with Patty at one time or another. And then Division of Appeals Policy is Nisha Marie Sherry. And there's a lot of cannibalism that goes on because we keep shifting people around. So Nisha was in Catherine's shop until a little while ago, and you know, I recruited her over to come and work on appeal policy. The Division of Appeal Operations is Maria Ramirez and Christina Kasdan, and they mostly are focused on the fee-for-service side of the house related to the appeals systems and operation. And then in the Division of Medicare Enrollment Coordination, we have Alina Chothuri, and she just recently joined us from the Plan Payment Group. So she brought with her some great experience from that side of the house. So that's my organization. Thank you.
There we go. Hi, everyone. I'm John Scott. I've been around the agency for a while. You may remember me from MEAG, MPPG, and Mudbug. I am currently the acting director of the Oversight and Enforcement Group, and together with Judy Gleaser, we manage basically these three divisions that you see on these slides here. We are responsible for auditing and managed care and Part D plans and issuing enforcement actions when required and when necessary. Like this slide shows, there are three basic divisions in the group. We have around 40 staff, 2 contractors, and we receive a lot of assistance from regional office staff too. So it's not just the 40 people. And if you've ever been through an audit before, you know that what I'm about to tell you is underselling all the work that goes on every day in the group. But if you haven't been part of an audit, we're working on that. So the three divisions are the Division of Analysis, Policy, and Strategy. Almost messed that up, thanks to Saturday Night Live. That is DAPS, and that division is led by Katie Flannery and Caroline Zeman. The Division of Audit Operations, DAO, which is led by Jessica Robinson, and the Division of Compliance Enforcement, which is led by Kevin Stansberry. All right. So DAPS, the way these are set out in the slide is basically how the workflow works within the group. DAPS establishes the strategy and policy for audits. They determine the number of audits that we will be conducting each year, which organizations will be audited. They create the audit protocol for new program areas that we might be auditing. They conduct the audits for PACE organizations, so that's a slightly different, and which you'll see in a second. DAO does the normal program audits, but all PACE audits are run out of DAPS, and again, with a lot of support from contractors and regional office staff, so it's not just us, and it would be impossible, given the number of PACE organizations that keep coming to the program, for us to keep up with that by ourselves. They also are responsible for the annual audit reports that you may have seen. Now there's two. There was one, just the program audits. Now there's the PACE audit report that was just published for the first time this year. Those are both on the cms.gov website if you've never seen those before. DAO, they in effect determine the audit schedule. They're all things operations related to the audit. So they determine the audit schedule for the program audits. They are responsible for the existing protocol, which is slightly different from what it used to be in the past for the program audits. They actually conduct the program audits, again, with help from contractors and RO staff. They are also now responsible for the collection of information related to the data that we collect during the audits. As you probably are familiar, we produced or put our 30-day package out, the PRA package out with the updated protocol. If you have questions about that, we're continuing to work on that and reevaluating that to some extent, thanks to your comments on that. Once an audit is in effect completed, there's a whole lot of work that goes into that process after that point. And obviously the DAO is responsible for managing the corrective action plans that result from that. And they also coordinate all audit training for CMS staff and our contractors. So there are some issues that must get referred on to the Division of Compliance Enforcement. I'll try not to say that too fast. So they receive these and evaluate these enforcement action referrals from DAO, regional offices, CPI, lots of places, OFM, MCAG, Mudbug. We get from Linda, from Tim Rowe. We see a lot of actions or potential referrals, and and DC is responsible for evaluating those. Although most of the actions we take come from the audits. Kevin and team work with the organizations to determine the severity and the extent of the findings, and determine if an enforcement action, which is a civil money penalty, a sanction, or a termination is warranted. They collect the CMPs. They manage the process for any org that has the unfortunate situation of being under a sanction. And again, that's with help from the regional office account managers. And DC also contributes to the annual reports. And that is, in a nutshell, what we do.
So I'm sorry to interrupt. In my attempt to be funny, I forgot to introduce the most critical person in my operation, which is my deputy, Jen Smith. And she's sitting directly in my line of sight as I'm reading my slides. And she's also going to cover the Q&A at the end of the day for me, and I still forgot her. So I apologize, Jen. She's an invaluable member of my team. Thank you.
And I did the same thing. So my deputy is Scott Strali, and he's in the audience as well in the back there. So apologies, Scott.
Just sad because he probably wrote those jokes for you.
He did not. Although I will say he is extremely extroverted and the opposite of me. So we make a good team.
Thanks. I'm Rebecca Paul, and I am representing the Medicare Plan Payment Group today. Jennifer Harlow is our acting group director, and she's unavailable to make it. So I'm here representing the work that all of us do. There are 6 divisions in the Plan Payment Group. 3 of them are operations divisions, 2 are policy divisions, and then there's a division of payment validation. I'm just going to start with the Division of Payment Systems, which, despite its name, is the first policy division. They develop and implement Part C and Part D payment policy, including bidding rules and rate calculation rules. They're the folks who are writing regulations, and they produce the advance notice and rate announcement out of their shops. They're doing a lot of the rule development for payment policy. They also develop and implement the MLR rules, collect and analyze the MLR data. And Jennifer Harlow is the acting division director for the Division of Payment Systems. The second policy division is the Division of Payment Policy, which again, despite its name, does the risk adjustment part, not all the payment policy part. Monica Ritasante runs this shop. This division evaluates, researches, develops, and maintains all of our risk adjustment models. So this is the Part C model that we use to pay the Medicare Advantage plans and some demonstration plans, the Part D model, the ESRD model, and the model that we use to pay PACE organizations. They produce the risk adjustment sections in the advance notice. They also develop, update, and implement risk score calculation methodology, and develop and update the frailty model and its application and payment. We use the frailty model for both PACE and FIDUSNet plans. I'm going to switch to the operations division. The first operations division is that I'll mention is the division of encounter data and risk adjustment operations. We have a couple folks who are taking advantages of new opportunities, and starting on Monday, Amanda Johnson will be the acting division director for DREO. This is the division that collects and processes all our risk adjustment data, so our RAPS data and all the encounter data. They oversee and maintain the front ends for those systems and the back ends as well. They're overseeing the system maintenance. DREO also operates the filtering methodology. This is the operations where we identify the risk adjustment eligible diagnoses on the encounter data records that plans submit. They calculate all the risk scores, all the beneficiary level risk scores that go into the payment system, monitor and evaluate data submission, and they provide a lot of technical assistance to plans, either through the front-end contractor, through one-on-one calls and our user group calls that we have monthly. I already skipped this one. What's that?
I think you were one ahead.
Oh, I'm one ahead. All right, we'll go back to the first one. All right, now I'm caught up. The next division, operational division, is the division of payment reconciliation. Christine, this is again a shift starting next Monday. Christine Macon is going to be running that division. They collect all the Part D data. This is all the PDEs, the front end and the back end, the DIR data, perform reconciliation and reopenings, and the reconciliation for the coverage gap discount program. They're also managing the retiree drug subsidy program, and they're doing all the payment appeals for Part D and the retiree drug subsidy program. And then our third operation division is the division of payment operations. Oh no, I'm doing that. So this is Ed Howard and his deputy, Heather Rudo. They are the business owner for Marks. This is the system that runs all of our monthly payments. They calculate all the beneficiary level payments. They're running the risk adjustment recon at mid-year and final. They're doing all the retroactive payment adjustments that get processed, putting in all of the monthly payment reports. They also oversee the system that aggregates all the payments and gets sent to Treasury for payment. They operate the help desk as well. And last but not least is our division of payment validation. And this is the division that does all of our payment validation on a monthly basis. So they're running all the payments in parallel and checking the payment system. They also do calculate our payment error rates for Part C and Part D. They also are the ones that develop and put out overpayment guidance and the operational guidance for the overpayment recoveries. So they're the ones who manage the HPMS overpayment module and oversee the overpayment appeals process. So 0 on the timer.
Yep.
Okay.
I think that's it.
Okay, so we are out of time for this session, but I would like to thank our panel of directors for sharing information on CMS operations and their groups. Thank you. All right, so if you'd like to evaluate this session, go ahead and take out your cell phone or go to that web browser and select A, and then follow that link. It is time for a quick 15-minute break, so please return promptly at 2:15 for our next session. And remember, if you have any questions, send them in via the SurveyMonkey link that is found in the participant survey instructions on the website. Thank you so much. See you at 2:15. Welcome back, everyone. Yep, that's your cue to take your seats. Hello. I have a lot of chatty people out there today. That's a good thing. Okay, well, welcome back to those that are in attendance with us here in Baltimore and those, of course, with us viewing via the webcast. We're glad to have you back and on time. So just a couple reminders real quick. Remember to send in your questions for the speakers via the link provided on the CTEO webpage. And we will have an open Q&A session at the end of the day where our speakers will return and give you an opportunity to ask them questions. Also, if you would like to provide feedback for today's event, a link to the event survey will be emailed to you at the end of today's session. And it can also be found in the participant survey instructions on the CTEO website. And for our in-house guests, the QR code to connect to these surveys is on the card that is on the tables in front of you. So please consider taking a few moments to complete the participant experience survey. Well, I'm excited to introduce to you our keynote speaker today, the Principal Deputy Administrator and Director for the Center for Medicare, Dimitrios Kozoukis.
How are you all doing? Did you enjoy meeting our group directors? Okay, well that's great. I really enjoy working with them every day. So I thought when we were thinking about the agenda for this conference that you all should get a chance to see them a little bit more as well. And so glad that you had that opportunity. I want to thank you all for joining us today at this 2018 Medicare Advantage and Prescription Drug Plan Fall Conference. It's a pleasure to be here and to discuss the important steps that CMS is taking to strengthen the Medicare Advantage and Part D programs for our nation's seniors and people with disabilities. As you know, open enrollment 2019 is right around the corner. This is my favorite Medicare time of year because beneficiaries are in the driver's seat. They get to review all of their new options and pick the plan that best fits their individual needs. And through these selections, they clearly signal what matters most to them. As such, beneficiaries, through their decisions, determine which plan offerings are going to thrive and which will not. I'd like to talk at a high level about why this is so important, how it fits into our broader healthcare agenda, and then in a greater detail about our work that's ongoing to ensure open enrollment in the next plan year is a success for beneficiaries. First, the high level. The open enrollment process, as I described, puts into operation our vision for transforming the healthcare system from one that pays for procedures and sickness to one that pays for value and outcomes. This is a statement that many might find difficult to quarrel with. After all, value sounds good to everyone. But what, you might ask, does value mean? To us, value means putting patients in the driver's seat, so they are making their own determinations about the care they receive instead of having procedures or tests done to them in a passive manner. And what better mechanism is there for putting patients in the driver's seat than giving them a broad range of options where local, national, regional organizations of varying shapes and sizes with different care approaches and philosophies and networks compete for each beneficiary's business, either against other plans or against the fee-for-service options that Medicare beneficiaries also have. And so the answer to that question, being that this is the optimal way to bring about that very outcome, we have embarked on a series of regulatory and other changes in Medicare Advantage and Part D that maximize the ability of beneficiaries to choose a plan that's right for them and offers the benefits that work for them. I've talked about that in past conferences, and so we don't need to go over a lot of that again, but I wanted to make sure that you knew that that work is ongoing and that it contains several steps beyond the changes in regulation and sub-regulatory guidance that we've already put out, and also that it fits into a broader agenda. In fact, this work is a centerpiece in a broader agenda to unleash the same market forces and competition in order to promote innovation and empower patients by providing flexibility and reducing burden. We are working ambitiously towards those goals, not just in Medicare Advantage, but also in fee-for-service Medicare. You may have noticed that in that program, we are, 1, making important changes to eliminate regulatory distortions from payment policy, as with several site neutrality proposals in this year's fee-for-service payment rules. 2, we are dramatically reducing burden in successive changes to many Medicare payment systems, including, for example, a proposed change to how Medicare pays for evaluation and management, which comprise 20% of the physician fee schedule payments. 3, we are looking to markets to set prices as we have with our proposed changes to payment for durable medical equipment and clinical laboratory services. 4, we have made or have proposed overhauls to how Medicare pays skilled nursing and home health providers to base payment on the total care they are expected to provide rather than line item services. All of this work, along with other mechanisms like making health information more portable so patients can shop for care, will make for a more competitive and dynamic healthcare marketplace. Our expectation is that Medicare Advantage program will not only keep up, but will lead the way in using the even greater flexibility afforded plans in how they pay providers, what supplemental benefits they offer, and otherwise to restructure the healthcare system to suit the needs of each patient as consumers drive patient change and plans find ways to innovate and adapt and serve. Now, on to some of the more specific changes we have made to increase the efficiency of the application process and to support beneficiaries in the plan selection process this fall. First, chronologically at least, in the application process, we implemented network reviews every 3 years to increase their frequency and also align with operational readiness and compliance rather than shoehorn the important activity into the application process. We've talked about this before. What's new this year is that to help organizations understand potential network review, we have begun a consultation review that includes a team of regional and central office working collaboratively with organizations to resolve network deficiencies. We understand that organizations that participated in this dialogue with CMS have found the process beneficial, and we intend to continue the work next year. We encourage organizations that have participated to share their feedback with their account managers so that we can improve the monitoring of our networks and improve the way that we work with you to ensure that. In addition, in preparation for the 2019 marketing season, we released the Medicare Communications and Marketing Guidelines. And when I spoke at the spring conference, I talked a little bit about those guidelines and the kinds of things that might be in them. We've now gone through that process, and we're pleased that we have included several new policies based on our regulations for 2019 as well as on your valuable feedback. We expect the new guidelines will lead to greater competition and value for beneficiaries. The new guidelines now make it clear that providers may choose to discuss plans with enrollees to ensure that the plan meets beneficiary health care needs. With these changes, we aim to allow more in-depth discussions between providers and enrollees, as well as sharing materials that can help in the course of the beneficiary's treatment. Another exciting change more clearly defines the difference between plan communication and marketing, with increased flexibility in how plans communicate with beneficiaries. We also provided more concise information on required documents, so you will more easily know whether these documents are marketing or communications and how or whether they need to be submitted, reducing the number of materials requiring submission. And we have also allowed plans to provide more information by way of comparison to other plans. We are confident that these changes allow us to maintain the necessary beneficiary protections that have always driven marketing policy and also provide important information to beneficiaries so they can make those informed choices that we think will drive change at the healthcare system level as well. Also, beginning this open enrollment period, CMS will be unveiling new tools and features to help our beneficiaries make even better decisions about their enrollments in Medicare plans. This is continuing Administrator Verma's commitment to modernizing the program by bringing it into the digital age for our beneficiaries. The features include helping our beneficiaries understand their out-of-pocket costs with a standalone, mobile-optimized cost calculator, which will provide information on both overall health benefit costs and prescription drug benefit costs. An improved coverage wizard, which will help beneficiaries compare coverage options at a deeper level as a way to decide if original Medicare or Medicare Advantage is right for them. A simplified login for Medicare Plan Finder tool using a beneficiary's online account instead of the current cumbersome process of using 5 pieces of information to authenticate. And a web chat pilot for a portion of those using the Medicare Plan Finder. In addition to preparations for open enrollment, another key priority for the administration is to reduce the cost of prescription drugs through competition and beneficiary choice. This summer, we announced several changes that will bring down the costs of drugs and improve choices for Medicare Advantage and Part D beneficiaries through greater negotiation and competition on behalf of beneficiaries. Last month, we announced that for the first time, Medicare Advantage plans have the option of offering patients step therapy. In other words, MA plans can now tailor their benefit so that the patients receive the most preferred drug therapy first and then progress to other therapies as part of a broader care coordination activity. This will enable plans to better negotiate deals for Medicare patients and create competition between drugs used to treat the same conditions. In providing this option, we also included essential guardrails to protect patients, including that the requirement must be communicated to enrollees through the upcoming annual notice of change and evidence of coverage documents. If your plan wasn't able to put together a step therapy concept in time for this year's rule, I urge you to consider utilizing this flexibility for next year. Speaking of next year, or next year, that is. Speaking of 2020, last week we also announced a new tool in Part D to expand choices and lower drug prices for patients. Specifically, starting in 2020, plans will be able to tailor their formularies so different drugs can be included for different indications. This policy, known as indication-based formulary design, will provide Part D beneficiaries with more drug choices and will empower beneficiaries to select a plan that's designed to meet their particular needs by covering the best drug for each patient condition. We expect plans will have more negotiating power with drug companies, which will result in lower prices for Medicare beneficiaries. We expect this policy will increase both the number of drugs available on a given plan's formulary and the diversity of plan formularies available. It's a significant step in modernizing the Part D program by giving plans a tool that serves patients well in the private sector. To help ensure that Medicare enrollees understand their coverage, we will update our online tool so that beneficiaries will see that a plan's coverage for a drug varies by indication before they make a choice in 2019 for their 2020 plan, as well as communicate the change to beneficiaries through other mechanisms and require plans to provide the information in their ANAC and EOC. You can see a pattern emerging here, that consistently we are looking to drive change in the healthcare system through the choices made by individual beneficiaries and to increase the array of options that beneficiaries have in a more competitive marketplace to make choices that make sense for them. I wanted to make sure that I also touched on the work that we're doing to combat the opioid crisis. It's an important aspect of our other activities in addition to the thematic competitive changes that we just talked about. These changes are focused on bold steps to fight the opioid epidemic. We have, as you know, established final rules for drug management programs for beneficiaries determined to be at risk, limiting access to opioids and benzodiazepines to selected prescribers or pharmacies in particular cases. We have also expanded the already successful overutilization monitoring system to support drug management programs by identifying beneficiaries potentially at risk. We are expecting all sponsors to implement a real-time opioid care coordination safety edit for high-risk opioid users based on a cumulative level of opioids at the time of dispensing as a proactive step to engage patients and prescribers about overdose risk and prevention. And we're setting expectations for setting safety edits at the pharmacy counter to limit initial opioid fills for the treatment of acute pain to no more than 7-day supply. You're familiar with these policies as they're ones we've already announced. What's been our focus this year in this area has been in terms of how do we make sure that this is implemented in a way that's most successful for beneficiaries. We've begun engaging with Part D sponsors, PBMs, pharmacies, and other stakeholders to implement the new policies. For example, we are developing technical guidance and beneficiary notices, revising user guides, updating systems, all to facilitate information and data sharing among CMS and plans. We will release a number of these documents this fall. We understand the need for educating physicians, pharmacists, and beneficiaries on their roles and responsibilities in implementing the various policies, and we are developing a variety of materials to supplement sponsors' education and outreach efforts. We've also initiated the Opioid Safety Edit Pilot, partnering with Part D sponsors and PBMs that have volunteered to test opioid-naive and care coordination safety edits, educational outreach, and industry preparedness. The findings from this pilot will inform additional technical guidance to be released this fall. We are working with NCPDP to revise the current telecommunication and script standards to accommodate implementation of the new opioid safety edits. And we have engaged several Part D sponsors to speak to you today about other innovative approaches to their organizations are taking to address the opioid crisis. Thank you for joining us for today's conference. Thank you for engaging with our staff. Thank you for working to serve the Medicare beneficiaries that you interact with every day or help interact with. And we look forward to continuing to work with you to deliver value and expanded choices for Medicare beneficiaries.
We would like to thank Demetrios for joining us today and sharing with us his vision. Our next speakers will provide participants with an introduction to the Quality Payment Program and a new demonstration proposed by CMS entitled the Medicare Advantage Qualifying Payment Arrangement Incentive Demonstration. It is my pleasure to introduce to you from the Division of Alternative Payment Model Infrastructure, Adam Conway, and from the Division of Delivery System Demonstrations, Jason Petrosky.
Great, thank you very much for having us. Are these live? Can you folks hear us okay? No.
Can you hear me?
Jason's going to do the whole presentation. We'll share, it's fine. Okay. Yeah, we're happy to share. So again, thank you for having us. My name is Adam Conway. Jason and I both work in the CMS Innovation Center. We're responsible largely for introducing a number of new payment models, and we'll talk a little bit about that, but mostly we're going to talk about the interactions between this new demonstration and what is called the Quality Payment Program. And so just to sort of provide a little bit of a, my power's not on. A little bit of an orientation to our discussion today. We're going to spend the first half talking about what's called the Quality Payment Program. And then the second half, Jason's going to discuss the demonstration and next steps and ways that your organizations can perhaps provide some assistance. So we wanted to provide a little bit of context here for the world that we're discussing. First of all, want to sort of emphasize that we're talking about Medicare fee-for-service and the ways that payment under Medicare fee-for-service have changed or will change under this program. So QPP and MACRA, which is the Medicare Access and CHIP Reauthorization Act, stem from what's known as the sustainable growth rate. I'm sure everyone's familiar, but essentially there were a number of fixes to the ways that doctors were paid, sort of decreasing the amount of relative increase in price year over year. Those were temporarily delayed year over year until at some point, I think we were looking at a 21% cut to the rates that doctors would be paid if the program had gone into effect. And so MACRA was enacted to create that fix. This was in 2015. And the Quality Payment Program is a significant part of MACRA. So the Quality Payment Program, or QPP, reforms the way that Part B payments are made. Again, this is Medicare fee-for-service. This 600,000 figure is approximate, but it certainly is relatively accurate. We believe that in various ways, clinicians who are being paid fee-for-service under Part B are having their payments adjusted in various ways through the Quality Payment Program. And the idea is, of course, that it will improve care across the delivery system. So clinicians have a couple of choices about the ways that they interact with the Quality Payment Program. There are two tracks that we have offered. One is called MIPS, or the Merit-Based Incentive Payment System. MIPS essentially is a sort of conglomeration of some legacy reporting programs, and will be rolling out, has rolled out this year. The other alternative is through the Advanced Alternative Payment Track. A lot of those alternative payment models are run out of the Innovation Center, but also include the Medicare Shared Savings Program. Doctors and clinicians may choose to participate in various ways depending on their specialty, location, patient population, practice size, and so these are the two tracks that we'll be discussing today. And I do want to focus in specifically on advanced APMs and APMs more broadly. That will be sort of our narrowing until we get to the demonstration. So just to touch briefly upon MIPS, which again is the merit-based incentive payment system. we want to talk about who's excluded here. So those include folks who are newly enrolled in Medicare, those who are not seeing a significant number of patients through Medicare fee-for-service, and those thresholds are up on the board there. And also those who are participating to a significant degree in advanced alternative payment models. Those thresholds for participation change. They will jump in 2019, which is part of the reason that we're here to discuss this today. I want to also flag that MACI, the demonstration we're going to discuss today, is another potential exclusion, and Jason will talk more about that. There's also, I'll talk a little bit more about this in a couple of slides, but there's an option for inclusion or exclusion from MIPS based on sort of middle range participation in advanced alternative payment models. So again, we're narrowing down here. Alternative payment models are essentially new ways for paying for care. The Innovation Center, as I mentioned, has rolled out a number of new payment models in addition to service delivery models, which are not payment models per se, but ways that services delivered, education models, for instance, models that coordinate different state or sub-state entities to assist in improving the delivery of care. And then also there are a number of congressionally defined demonstrations that CMS conducts that fall into this category. And we'll get a little bit more specific about what we're talking about in the next slide here. So again, the MACRA statute and successive quality payment program regulations have defined alternative payment models in a couple of ways. One is a model that we run out of the Innovation Center, with the exception of a number of grant programs which are now sunsetting, the Healthcare Innovation Award grants. Another is the Medicare Shared Savings Program. So obviously there's a new rule for the Shared Savings Program that just came out this summer, and that defines a number of tracks, but that is categorically is included as a alternative payment model. We also include demonstrations under the Healthcare Quality Demonstration Program and a demonstration required by federal law. And now we're going to narrow down to advanced alternative payment models, which is a sort of a further refinement. Advanced alternative payment models have a number of criteria that must be met. Those are broadly EHR use, quality measures, and financial risk, and I'll talk a little bit more about those. So the first is EHR use, and the model design itself must require the participants to use electronic health record technology. The second is that services that are paid that are either covered professional services under Part B or services that look very much like those services are paid based on performance and quality measures that are either on the MIPS quality performance list or comparable. And then the third, which is this risk criteria, has two components. And one is either the model is a medical home that is expanded under the Innovation Center authority. I'll note that that has not yet occurred, so we'll just put that aside for a moment. But the other category of risk is that participants have to bear more than a nominal amount of financial risk. And so, I think that's enough, I'll say that. There's a lot to be said about the ways that we define financial risk, and there are a number of tiers within that. Happy to discuss that with anyone who's interested later, but for now, I think that's sufficient. So the benefits of participating in an advanced alternative payment model are on the board here. Also, and this is not on the board, but there are inherent benefits to the model itself. So for instance, under the Shared Savings Program, participants can share in savings and receive a payment in that way. But also under the Quality Payment Program, they are excluded from MIPS reporting, and so that reduces their burden, their reporting burden. There's also the potential, again, with sufficient participation, to receive an incentive payment that is equal to 5% of their Part B covered professional services for the year, so that's not insignificant. And then beginning significant later in the program in 2026, The physician fee schedule updates that are issued each year will be higher for those that are at this higher level of participation under an advanced alternative payment model. So that is, again, all Medicare fee-for-service up until this point. I'm going to shift here slightly, which is going to get us toward the demonstration that Jason's going to talk about, which is because there are a sort of a threshold that you need to meet in order to meet that QP status, which again is the status which makes you eligible for that 5% incentive. That threshold for reaching that status increases in 2019. It goes up to 75% in some cases. And so what we have done through the statute is to allow for other payers to be included in the calculation that we do. So up until this point, we're doing just Medicare dollars, those dollars seen through the model over those eligible to be seen through the model, in other words. And as those thresholds jump, we recognize that those thresholds are harder to meet, succeed under those thresholds, and so we bring in other payers. So I'll go through with those payers on the next slide, but that is the purpose here, is to make sure that those who are participating more broadly in advanced alternative payment models, sort of across their payer spectrum, have additional opportunities to reach that status and get that 5% benefit. And that's why Medicare Advantage cares. So those payers that we include in this calculation are obviously Medicare health plans, including Medicare Advantage, Title 19, also payment arrangements for commercial payers or Medicaid, Medicare Advantage, that are aligned with one of our multi-payer models. So at this particular moment, that means the oncology care model run out of the Innovation Center, but also the comprehensive primary care plus model, so medical home model, also run out of the Innovation Center. So payers that are aligned with those models are allowed to be considered under this arrangement. And then finally, other commercial and private payers, and that is rolling in 2019. And so finally, I'm going to turn this over to Jason in a second here, but I just want to reiterate that all I've said up until this point is largely about Medicare fee-for-service, but the Quality Payment Program is changing the way that fee-for-service is paid. If you're a QP, which is again one of those folks who's in an advanced alternative payment model to a sufficient degree, they have that 5% bonus, they have a waiver from reporting requirements, and as you can see, there are these two options staggered in over time, where either they're reaching that status under Medicare only or all payer beginning in 2019. Partial QPs, which I alluded to earlier, are those who don't quite reach the threshold necessary for the 5% incentive, but are sort of somewhere in the middle between 0 and that threshold. They have the option to report under MIPS, which may have a positive adjustment, obviously, or they can be excluded from that reporting burden. MACI, which obviously Jason's going to talk about in a second here, and MIPS. And there's a fourth category, which is perhaps a little confusing, but there are alternative payment models that incorporate reporting requirements that are very similar to MIPS. Those also have a reduced reporting burden because they're reporting through their model. And with that, I'm going to turn it over to Jason, and we can switch microphones here.
Okay, thanks, Adam. As Adam mentioned, there's a couple of different ways that CMS has been operationalizing or plans to operationalize Part B payments for clinicians. And in 2018, CMS actually announced a proposal to do a new demonstration project called the Medicare Advantage Qualifying Payment Arrangement Incentive Demonstration. Quite a mouthful, so we just call it MACI. And MACI was announced recently in the 2019 Physician Fee Schedule proposed rule, and it's under development until that rule is finalized. The essence of MACI and where it fits in with Medicare Advantage and Part B payments is that it really focuses in on what do clinicians have sufficient participation in advanced APM-like payment arrangements with Medicare Advantage organizations. So Adam spoke a bit about advanced APMs and, what those arrangements look like, what are the criteria that CMS is looking for. We'll get into that a little bit more in some of the other slides. But the focus here, if you leave this presentation, or at least the Mackey piece here with anything, it's that in this demonstration we're looking at a way that tries to find similarities between the fee-for-service APMs, like the models that Adam talked about, but in the MA space. So as part of this rule, we are proposing a 5-year demonstration project, and the first performance year would be this year in 2018. Again, so why would we test this project? Why do as a demonstration? Again, this demonstration would focus in on Part B clinicians who participate to a sufficient degree in certain payment arrangements with MAOs and who otherwise would have not achieved QP status through other options, or they wouldn't have otherwise been excluded from MIPS. So it fits clinicians in a certain space. What would we want to test in this project? The test in this demonstration would be whether providing clinicians with an exemption from MIPS reporting requirements and payment adjustments maintains or increases participation in advanced APM-like payment arrangements in MA plans, and it also changes, or whether it changes, the manner in which clinicians deliver care. CMS thinks that this is something worthwhile to test because MAOs may have or are considering innovative payment arrangements that already resemble advanced APMs. However, without this demonstration, physicians may still be subject to MIPS, even if they participate extensively in these types of arrangements. And the last piece of testing this is what is our authority. So our authority to conduct this demonstration or this test is under Section 402 of the Social Security Amendments of 1967. So who's eligible for the project? What can clinicians get out of being a part of the demonstration, and how does CMS determine whether someone that has applied, a clinician that's applied, achieves those waivers or not. First, to be eligible, a clinician must meet the definition of a MIPS eligible clinician under the Quality Payment Program as defined under the federal regulation mentioned here. Participation in this project, the waivers afforded under the Mackey demonstration are around exemptions from MIPS reporting requirements and payment adjustments. A key thing here to point out is that this project does not provide a financial incentive like the QPP program. It does give relief from potentially the MIPS reporting requirements, and it has no impact on payment adjustments, so it's not equivalent to the QP status that Adam talked about previously. In order to get these waivers, to get the waivers from MIPS reporting and payment consequences, CMS will review the following information, and this is very similar to some of the information that Adam talked about. So the first piece is, do you have a qualifying payment arrangement with a Medicare Advantage organization? Really, this is, this is the clinician's contract with the MAO. Does it meet the requirements? Does it have the features that Adam talked about before? And I'll go a little bit more into detail there. The second piece is we talk a lot about sufficient participation, and that really just means the number of beneficiaries that a clinician is seeing. Are they attached with this Medicare Advantage organization that has that type of contract that we're looking for? So that's what we mean by sufficient participation, and you'll hear us refer to this as like threshold. Has a clinician met the threshold for having sufficient participation with these advanced APM-like arrangements with MAOs? So those are the two overarching criteria in which we would look at to determine if a clinician is able to get the waivers under this demonstration. On the left side of this slide is basically the same information that Adam provided. These are the core requirements for the arrangements with MAOs that we would be looking at. EHR use. Are you using quality measures that are comparable to those used in MIPS? And the last piece, which Adam spent some time on, which is, do your arrangements with MAOs have more than just nominal financial risk? So those are the criteria or the core requirements that we would look at in looking to see if a clinician has a qualifying payment arrangement with a Medicare Advantage plan. And how would we determine that? The information that we'll be soliciting from clinicians, and this is important for this audience because you guys can help out here. The information that we'll be soliciting from clinicians starting in 2018 is, give us the name and payer of your payment arrangement, a description of how the payment arrangements meet our requirements to the left, and then we'll also, be requesting specific documentation. And as I mentioned on this, this slide again reiterates we're basically using the same criteria here for requirements for the waivers as they're using in the other payer advance APM option of QPP. So big picture, Mackie in the context of QPP, there's for all of these paths for CMS determining adjustments to fee-for-service payments or Part B payments, there's an outcome. And starting on the left, if you've achieved QP status, the big takeaway is you get a 5% incentive payment or bump. If you're a partial QP, you have a choice of whether to participate in MIPS or not. If you're MIPS eligible and you fall under the MIPS program, then at the end of the day, you could have a positive, negative, or neutral fee-for-service payment adjustment based on how the scoring pans out and how you do on the quality measures, et cetera. So the outcome for Mackie, again, just to reiterate, there is no payment adjustment. It's really a MIPS exemption from reporting and having any up or down adjustment made to your payment. So what can you all do as members of MAOs or part of the industry? First thing you can do is let your clinicians know about this opportunity. If you think that that your plan has types of arrangements that meet these requirements, or even if you don't, start the dialogue with your clinicians and see if this is something that they should look into, especially if your clinicians see a significant number of MA patients relative to fee-for-service and other payer patients. That's where Mackie fits. We would also ask that you assist eligible clinicians in providing the QPA and threshold information. For 2018, we are asking clinicians to fill out information on these qualifying payment arrangements and threshold information. And your role could be to help them provide this information, maybe provide them template information that helps them fill out the forms. I'm sure they already have the contracts, but anything you can do to help with the individual clinicians submitting this information to see if they achieve the waivers would be helpful. And then lastly, obviously, if the intent of this project is to encourage innovation, to encourage APM-like arrangements in Medicare Advantage. So we'd ask you to consider innovative changes and or new arrangements with clinicians if you haven't done so already. So for clinicians that are interested, and really this is kind of like where we're at in our timeline for 2018, the first part of our process was really to just have clinicians raise their hand and say you're interested and put in an application. That application actually ends today. And then we'll move to the next part of the process, which is where we try to see if clinicians have these qualifying payment arrangements and they have a sufficient enough population in these arrangements to meet our requirements. And that's where you as the health plans can help, again, clinicians fill out the next set of forms, which is the QPA and the threshold information. And again, that's necessary for CMS to collect that to see if these clinicians have they meet the requirements for the project. And then finally, after CMS has reviewed the information provided, we will be notifying clinicians in late 2018, early 2019 to let them know before MIPS reporting happens and so forth, whether they've received the waivers or not. So lastly, these two links on the last slide here provide websites. The first one for the Mackey demonstration. Again, the Mackey demonstration is under development right now. It will be finalized when the 2019 physician fee schedule rule is finalized, but you can go out there and see what we've proposed to date, or you can go into the rule, obviously. And then for more information on the quality payment program, Adam's provided a link here. So with that, I'll turn it back over to Stacy.
Okay, thank you. So we do have some time for questions. So if there is anyone in the in-house audience who has a question, please step up to the microphone. There's movement, but I can't tell if you're leaving or if you're stepping up to the microphone. Okay, so it doesn't look like we have any particular questions right now for Adam and Jason. So at this time, I would like to thank them for providing a clearer understanding of what CMS proposes to study. So thank you very much.
Thank you.
And what we are going to do at this time is we are going to move into some trivia questions from CMS. So get those cell phones ready to do some responding, or go to that web browser and we'll see how you guys do. Oops. Oh, yeah, here we go. Okay. Do we need to go do the evaluation? Did I miss that? Okay. Oh, you guys are way ahead of me. So we are going to take a step backwards. And we need to do the session evaluation. And my apologies for that. I jumped ahead a little too quickly. So give us a minute here and the poll will open. And once that poll opens, if you'd like to evaluate the session, go ahead and select A. There we go. Again, my apologies for that. And then follow that link and go ahead and evaluate the session that was just presented. Give you a second to do that, and then we'll switch over to the trivia questions that you guys already began to answer. You may have to do it again. And while we are doing that, I would just like to go over a couple reminders for you. And that is that we do have the surveys, the post-event survey, participant survey that you can access by going to the CTO website and going into the participant survey document. Also in that document is the link to get to the CCB survey. So if you would like to obtain your CCB credits for today's event, you will need to complete that survey that details the sessions that you participated in, and that needs to be done by September 24th. So please take the time to do that also. All right, so our first question here, trivia question, sorry for those who already answered it once. In what year did a presidential health task force first recommend that the Medicare program cover outpatient prescription drugs? What year would that be? Would it be 1963, 1969, 1986, or 1993? And the responses are still rolling in. But we'll go ahead and we are going to give you the correct answer. And the correct answer is B, so 15% of you got that one correct. Nice job. And all right, so our next question. When Medicare began, what sort of efforts did hospitals and nursing homes need to make to integrate their facilities for Black and white patients? Was it a good faith effort? All deliberate speed? Integration was required before participation in the program began? Or facilities south of the Mason-Dixon line were exempt? Okay, it looks like we got responses in, and the correct answer is C. Integration was required before participation in the program could begin. Okay, we got a couple more here for you, and then we're going to move on to our next session for today. All right, our next question here. What agency originally administered Medicare? Was it HCFA, which is Healthcare Financing Administration, CMS, SSA, or SRS, Social and Rehabilitative Services? And okay, and the correct answer is C, the Social Security Administration. Awesome. All right. How about we do one more and then we will go ahead and move on. And that question is, which secretary established the Healthcare Financing Administration? Was it Secretary Califino, Secretary Cohen, Secretary Sullivan, or Secretary Thompson? Give you another second to send in those responses. How are you guys doing out there? Getting all the answers right? No? That's okay, me neither. All right. And the bars are starting to slow down a little. The correct answer is A, Secretary Califino. All right, I guess we all need to brush up a little bit on our CMS trivia. All right, so we will move on. Our next session features a panel discussion with plan sponsors who will provide a brief overview of the steps taken by health plan organizations to combat the opioid crisis. Please help me welcome Jacqueline Jacobson from Martins Point Healthcare, Erin McKenna from Aetna, Annie Schuster from Cigna HealthSpring, and Howard Shaps from WellCare Health Plans.
Thank you, Stacy. I'm delighted to be here this afternoon to share with you all how Martins Point is promoting benefit strategy and clinical opioid strategy alignment. To begin, I will outline the elements of a comprehensive opioid strategy. I will discuss the principles that are the foundation of that strategy. I will share our bid development best practices. I will talk to you about the importance of benefit agility and some strategies that organizations can take to advance their benefit agility. I will highlight some of our 2019 benefits that specifically address the opioid epidemic. And then I will talk about some of our strategies looking forward for our opioid mitigation. The Martins Point opioid mitigation strategy centers on the education and engagement of members, providers, and pharmacies. Appropriately, most of the elements are driven by Part D activities, health management programs, and access to services. All of the elements are supported and measured through data and analytics. But my focus today will be the discussion of how Part C benefits can complement Part D goals, especially with the new benefit opportunities that were available for contract year 2019. Shared principles are critical for benefit alignment and clinical opioid strategy alignment. Our lodestar is understanding our community's needs. In doing so, that will be able to inform how we engage with our members, the methods for working with providers as opposed to against providers. We are definitely recognizing that all stakeholders are doing what they can to tackle the opioid epidemic. We not only seek to remove barriers, but also to provide supports. Likewise, we seek not just to prevent opiate overuse, but also to alleviate existing opiate overuse. And finally, we think creatively amid a lack of access to services in our service area. Our best practice for incorporating these principles and promoting alignment throughout the bid development centers on the key consideration of how can Part C benefits support and complement our Part D goals. Our benefit strategy begins much earlier than bid development, and I cannot emphasize enough the importance of engaging strong clinical advisors early and often in your benefit strategy development. That is how you can identify opportunities for cooperative programs, benefits, and services. Throughout bid development itself, we fully integrate our Part D and clinical program partners. And even after the bid is submitted, the work is not done in prioritizing benefit alignment for opioid mitigation. Throughout desk review and rebate reallocation, anytime we have to increase our benefit to members, we prioritize maintaining and strengthening our supportive Part C benefits for our opioid mitigation goals. Now we are going to take a poll, and this is, in fact, a poll. There is no wrong answer, but I would like you to select the statement that best reflects your organization's readiness to implement several of the new benefit opportunities for 2019, such as the elimination of the meaningful difference test, uniformity flexibility, and the expanded scope of health-related supplemental benefits. That is really exciting. It's great to see that a lot of organizations, I'll give a couple more minutes or seconds for people to get in. All right, the results that are rolling in are more aligned with what my expectations would be for this group. I thought it would be important to discuss why our organization feels that benefit agility is important to addressing the opioid crisis. Because the opioid epidemic is so complex and ever-evolving, for us, we equate agility with our benefits to an ongoing ability to address the ever-evolving needs of our membership. I do want to reiterate that one of the key strategies is understanding our community needs again. We are always performing gap analyses between our benefit community needs, our care model and community needs, and assessing the provider and partner landscape. We also explore opportunities beyond what the current guidance allows by looking at successes that we're seeing through community-based organizations, other health plans, especially beyond Medicare plans, and what providers are doing. our mantra is sort of, it may not be allowed today, but it might be allowed tomorrow. And in so, we're really preparing ourselves to both anticipate and be responsive to CMS and new Medicare Advantage opportunities. Not only does that mean responding and commenting to CMS, not just when something may be an administrative burden or impact our rates, but also responding when we're excited about the new opportunities that are becoming available. And we are also building scenarios that we would like to see happen before the guidance is out. And we did that especially related to the opioid benefits I will discuss. So you're probably very curious at this point how Martins Point is leveraging our benefit agility to align our benefit and clinical opioid strategy. We did on the left-hand side, you'll see that we were able to incorporate a number of our principles with these new benefits. We're moving barriers and also providing support, engaging the member, and both preventing and alleviating opiate overuse. We're taking advantage of the new 29 opportunities of uniformity, flexibility, and the expanded scope of health-related supplemental benefits. You'll see for our first targeted disease state is opiate use disorder. For that, we are taking advantage of the reduced cost-sharing option of uniformity flexibility. So we are eliminating copays for individual and group mental health, substance abuse, and psychiatric therapies. In the next category, we are targeting both opiate use disorder and chronic pain syndrome. We already have alternative therapies in all of our health plans that include acupuncture, fitness, and naturopathic services. But for this group, we are adding additional supplemental benefits to support non-opioid pain management in the form of additional acupuncture as well as therapeutic massage as a part of their care plan. The backbone for both of these new benefits that we're offering in the new environment is that they require member participation in a plan-sponsored wellness or care management program. And those programs have a behavioral health focus, they emphasize care coordination, and they also work to address the social determinants of health. Looking forward, this is what we at Martins Point see as the drivers for our future comprehensive opioid strategy. First is our mission to build and create healthier communities. Both of the states in our service area were among those very hard hit by the opioid epidemic. We also want to improve our collection and use of data. We also want to collect information beyond the traditional data points that may be able to better help us care for our membership and enhance our care. We also want to grow our multidisciplinary stakeholder engagement through partnerships, such as a community-based network, so a non-traditional provider network, any way that we are able to amplify our impact with limited resources. And finally, innovation will keep moving our opioid strategy forward. We remain open to novel ways to address the opioid crisis. You are all welcome to reach out directly to me for questions. We will be going on with our panelists, so I'm going to pass it over to Erin McKenna from Aetna.
Thanks, Jackie. Ooh. I think I may have just turned it off.
Push it again. There it is.
Oh, there we go. Could you advance the slide, please? Thank you. Our organization worked to create a comprehensive opioid strategy, really with a focus on a very multidisciplinary team and across our enterprise. And we looked at it as really having three pillars in how we were going to certainly work within the requirements and guidelines of CMS, but at the same time, how could we go beyond? And so our three pillars we broke down as prevent, intervene, and support. If we can advance to the next slide, please. I want to talk a little bit about some of our prevention strategies. And obviously, we can't go through all of them, so I'm going to focus on a few key activities. So certainly, we have pharmacy and case management, but really working to use that opportunity when we're interacting with our members to talk about pain, to talk about alternative pain therapies, to really listen and learn and share with them those alternatives, not only in drug, but also whether it's an exercise opportunity, yoga, mindfulness training, some of the non-traditional ideas of chiropractic care, massage, really looking and talking about pain in its totality and highlighting the new treatment guidelines. We also work a lot with our special investigations unit, really mining the data, looking at fraud, waste, and abuse of opioids in its totality and connecting the dots through big data to help to prevent opportunities to misuse opioids. If you could advance the slide, please. Our second pillar that I wanted to highlight is in our intervene. Whenever we have the opportunity and we're working with our members, we have screening tools to really talk about opioid use disorder. Whether it's you're doing a fall risk prevention or a post-hospital discharge, any of those interventions, when the opportunity comes up in discussing pain, we really do focus on that discussion around pain and have the opportunity through our multidisciplinary teams to do behavioral health referrals, screenings, and assessments. If you can advance the slide. Our last pillar is support. It's not just about what we can do with a health plan at our large Aetna organization. We also look to how do we leverage our communities? How do we support the activities that really start at the grassroots within our communities and being a partner to them? So whether it's grants to help our first responders with access to Narcan, some innovative programs that are really developed at that local level to really be impactful in our communities that we serve. I want to spend the majority of our time today really highlighting how we kind of took this concept of prevent, intervene, and support in one of the programs that we launched this year. If you can advance to the next slide, please. So this year, Aetna launched what we call the Guardian Angel program, and we started by piloting this program, really looking at the data analytics and finding those members that have recently had a overdose event. So, you know, the ER claims, all of those types of touch points that really signal that we have an at-risk member. Sometimes we catch it before, sometimes it's really at that critical moment that they've had an overdose event, and reaching out to them. We have a trained registered nurse program that really, using this big data, we very quickly are reaching out to our members and offering them service, offering them support. And it's not always, you know, they may or may not be ready to discuss therapy. They may need more social support. They may need help in finding a provider that can get them on the road to treatment. There's the local programs, the various programs that are in all the communities, and using our resources, we help to direct members and really be part of their care and following up and being a touch base with a program. We also continue to look at the success of the program and truly just launched this year, but in the members that we have had the opportunity and the participation in this program, they're likening it to a lifeline. They've really developed a relationship, and we're there to really help in those critical moments with them. We continue to refine this to look to expand this program, as well as to say, what's our next step? Because you can't really, in this opioid epidemic, there's a lot of solutions out there, and it's a challenge at times because there are so many great ideas, but how do you launch, how do you test, how do you refine, and really take it to that next level? If you could advance the slide. So really the key takeaways, CMS has given us, in looking in 2019, certainly even more opportunities to really become part of that prevent, intervene, and support model to really be impactful in tackling the opioid epidemic. We took those solutions, but certainly added to them through really a creative, enterprise-wide, multidisciplinary team that we continue to refine and improve programs as well as launch new programs. If you could advance the slide, please. Certainly, I would welcome any questions. And with that, thank you for your time, and I'm going to turn you over to Annie.
All right, thanks, Erin. My name is Annie Schuster. I'm with Cigna HealthSpring, and I've been asked to focus on the efforts at Cigna that are beyond what our CMS required. What you'll hear through my presentation is an emphasis on collaboration. As we know, tackling the nation's opioid epidemic is a multifaceted issue, and then there's not one solution. So we've really been focusing on partnerships across, partnering organizations, associations, other healthcare professionals, our providers, community groups, et cetera. We recognize that more is needed to help our patients and help individuals who are struggling to manage pain, as well as those dealing with addiction. We recognize there's more needed to support their families as well as their communities. So what I've done is bucketed this presentation into 3 collaborations. The first is an internal aspect of collaborating. The second is related to our provider-facing efforts, and the third to our consumer engagement efforts. In May of 2016, Cigna brought together and stretched across our enterprise many different groups from pharmacy, behavioral, dental, regulatory, and more to discuss the issue, discuss ideas, bring forward solutions, and to complement that within our Cigna HealthSpring Medicare and Medicaid segment, we brought together our pharmacy, medical, and behavioral health teams to additionally talk through how we could operationalize the solutions and also leverage our physician partnership model and focus on how we could interrupt the cycle of addiction and ensure that for patients that have no other alternative to manage their pain, that they're receiving the clinically appropriate medication regimens as prescribed by their physicians. We continue to build on this collaboration, and so in the next slide I'll talk about a couple of examples of that. Okay. And as I mentioned before, we brought together our leaders of multiple areas, and although we had pre-existing engagements, with this enhanced focus, we were able to work together and identify where we needed to make adjustments to interventions as well as to develop additional ones. We recognize that the reduction in addressing the reduced risk of prescription opioid misuse is a key component. And so we had set our goal at 25% over 3 years, and we've made a lot of progress towards that goal. In just over 2 years within our segment, we were able to achieve that goal, and we continue to work on solutions to help improve and address the epidemic. An additional way of working together is that we brought our pharmacy and medical teams together. We, within our Pay for Quality program, which is a quality-based program where we provide additional dollars to providers who are able to achieve some outcomes-based and quality metrics that we have set. And with that partnership, we also provide additional support. So, for instance, nurses in their offices to help liaison with our membership. So through this Pay for Quality program, we introduced a 7-day acute use measure. With this measure, we have been able to raise awareness of which prescriptions are being written for greater than 7-day supplies, and to allow prescribers to see their prescribing patterns at a provider level and at a network level. And this kind of dovetails well onto the CMS 7-day edit that goes in place on 1/1/19. And our hope is that we've been able to raise awareness and change prescribing patterns prior to that in a manner that does not bring forward a potential access to care barrier. Additionally, through our partnership, we identified that we needed to make an investment, and in this area, we brought forward a 12-week substance use coaching program. The program focuses on allowing our members to have access to a behavioral health case manager. So if they're ready to talk, our coaches are listening, they're educating, and if they are recovering, they're being provided support and accountability. We're developing relapse prevention plans with them. We are helping connect them to community resources and 12-step groups and other resources in their communities, and we're really trying to support them through this continuum. One of our collaborations was that we were able to take our pharmacy retrospective drug utilization review prescriber outreach efforts, and for those that were based on algorithms where patients had high opioid levels, we were able to introduce this and allow the physician to have it as a discussion point for another intervention that they could discuss with their patient when they were meeting with them. All right. The Cigna HealthSpring provider engagement model is one focused on engaging, educating, and collaborating with our physician partners. We enter a market, and on a continuum basis, we look for thought leaders in that area to partner with them, to understand the community and understand where we could evolve that network and bring in other providers. There's bidirectional feedback throughout, and we're really focused on providing evidence-based medicine and improving care amongst the patients, our patients. In doing so, we brought our health plan medical directors and pharmacists to these engaged provider groups that we regularly see on a regular basis, and we brought our Cigna Pledge. And our Cigna Quality Improvement Opioid Pledge dovetails off of the U.S. Surgeon General's Turn the Tide Pledge, as well as the CDC opioid prescribing guidelines. And to date, we've had 9,000 provider groups and 130,000 prescribing clinicians sign our pledge. And the pledge, at first, the first part of it focuses on the Turn the Tide Pledge, which asks providers to commit to educating themselves to treat pain safe and effectively, screening patients for opioid use disorder and providing or connecting them with evidence-based treatment, and talking about and treating addiction as a chronic disease and not a moral failing. In addition, the Cigna Pledge asks prescribers to commit to taking steps to improve quality and coordination of care for patients receiving opioids. And lastly, ask them to reduce potentially avoidable opioid prescriptions when alternative therapies are available. So we recognize that in delivering this pledge, we wanted to provide our groups more, and so we provided a quality improvement playbook, and that playbook includes educational materials, or educational links, I should say, to such things as PDMP information and medical screenings for provider offices. Also, we were able to leverage key partners and solicit ways that they've focused on quality improvement initiatives within their provider groups, and we have examples of those within that within that playbook that providers could reference and implement within their offices. So these, as well as providing our physicians with potential overutilization or any concerns that we see, are ways that we try to continuously engage with our providers. All right, and last is our consumer engagement efforts, which we recognize are very important, is to raise awareness within our communities and to advance the concept of a pain plan. one that encourages conversations amongst individuals and healthcare providers about the safe use of opioids and other pain management options. Additionally, you may have seen our 1 in 5 campaign via social media outlets, but we focus here on the fact that with just a 10-day prescription and someone who hasn't had opioids before, 1 in 5 of us is at risk for an increased opioid addiction, and that any one of us can be that 1 in 5. So to assist, we are really trying to focus on protecting ourselves, and we have a dedicated pain resource hub that provides educational materials and talks about how pain manifests, how it's treated, and how to manage it safely that we encourage our communities to reference. We also are focused on ending the stigma of addiction, and we focus on, or we partner with groups such as Shatterproof and provide Cigna World of Difference grants to help advance that mission. In June, we've brought forward and intensified our commitment, and in addition to our national efforts, we're going to be providing within our local communities immediate and long-term solutions that we're going to be partnering on to make it easier to access substance use disorder treatment, including MAT, comprehensive pain management, and enhanced support and counseling, as well as naloxone availability. So we continue to enforce safe prescribing guidelines, coordinating care, and working towards an intensified commitment to reduce overdose death and risk. So we believe that strong community engagement is important for all the communities we live, and we believe that it's important to do it in a collaborative manner. All right, here's my email address should you have any further questions. And with that, I would like to turn it over to Dr. Howard Schaps.
Thanks, Annie. Good afternoon. So I am Dr. Howard Schaps. I am the Kentucky Market Medical Director for WellCare Health Plans. And over the next several minutes, I'll be speaking to you today about some of the clinical programs that we've instituted both at a national level and a local level. And a quick agenda. I'd like to give a little bit of background. I think some of the information that I'll talk about may have some overlap in general throughout the next 10 minutes or so. But the background is important just because it provides some context as to what we implemented over the last several years. I'll talk about our roadmap, which mirrors what CMS published in June of this year from a opioid epidemic standpoint, and talk about those programs, and then talk a little bit about the future as well. But when you look at the landscape from a Medicaid and Medicare lens, and I know this is a Medicare conference, but Medicaid, when you talk about clinical programs, there's definitely some translation back and forth between the two populations. Medicaid covers about 30% of Americans who are addicted to opioids, and Medicare is right behind. And if you look at WellCare, our Medicare Advantage population, depending on the state, averages somewhere between 40 and 50% duals. And while this is not the only population who's at risk for substance use disorder, poverty and behavioral health issues are often seen in this population, and that goes hand in hand with substance use disorder. If you want to get a little deeper, and I'll talk a little bit about Kentucky. In 2015, Kentucky prescribers wrote for 4.5 million prescriptions of opioids. That's 97 prescriptions for every 100 citizens of the Commonwealth. If you look at 2016, there were 989 deaths from opioid overdoses. This is about 24 for every 100,000 citizens of the Commonwealth, which is almost double the national average. And I'll go a little bit deeper as well. If you look at an article that was written in The Atlantic back in February 2017, it talked about Manchester, Kentucky, has 1,500 residents, 11 pharmacies, and most of which are independent pharmacies, which sits in Clay County, which has 21,000 residents, and this is pretty deep into southeastern Kentucky. In the 12 months that ended in September of 2016, Clay County residents filled 2.2 million doses of hydrocodone and 617,000 doses of oxycodone. So that's about 134 prescriptions for every man, woman, and child who live in Clay County. So let me pivot a little bit and talk about our roadmap. And again, a little bit of overlap from what we've heard earlier. But when we look at it from a prevention treatment and data standpoint. Data is important, and the beauty of being a payer is that we have access to pharmacy data, we have access to medical data as well. And that translates into clinical programs that we can implement and then run and operationalize in our markets. From a prevention standpoint, I initially think about how I can identify which members may be at risk for opioid use disorder. I can get my providers and my care managers involved. And as we heard earlier, in the social side of medicine, the social side always complements the behavioral health and the medical side. But from an identification standpoint, it's just a matter of how you use that data. You can look at it from the medical side. I can look at members who have chronic pain syndromes. Have they had visits for chronic headaches, chronic back pain, neuropathic pain? Can I see which members are going to the emergency department, probably a little bit more than they should? And from a pharmacy standpoint, it's a matter of how you look at who's filling what prescriptions, but you can look to see who's taking an opioid with a benzodiazepine, which is always not the best combination, or you can also look to see who's taking a prenatal vitamin with an opioid. And perhaps you can get in front of those members who may have a risk for neonatal abstinence syndrome. When I talk about treatment, it takes a village, and there's not a magic wand, there's not a magic potion, but it's really getting the community involved and then complementing that with medication-assisted therapy, so the buprenorphine products or injectables such as Vivitrol, and then finally, getting the behavioral health side addressed as well. It could be intensive outpatient, it could be outpatient therapy, it could be residential, but if you don't have the social side connected to the medical and behavioral health side, it's really hard to make a difference. And that's when we started developing our programs, that's the road that we went down. So I'm not going to talk a whole lot about care management. I'm not going to talk a ton about provider partnerships. I want to intertwine that into the next couple slides or so. But I don't want to forget that my care managers do a wonderful job every day addressing the transportation, the food, the shelter issues that we have with our members, whether they be Medicare or Medicaid. And from a provider standpoint, if we can't work with our providers, there's no way we're going to be successful dealing with the opioid crisis that we're all dealing with. So the first program I wanted to mention was our pharmacy management program that we implemented in Kentucky. In 2016, towards the end of the year, we identified about 1,300 members who we thought were at risk for opioid use disorder or had opioid use disorder. They were using multiple pharmacies, multiple prescribers, and they were taking multiple different types of opioids. And we intervened. We assigned them to one prescriber, one pharmacy, and one care manager. And that care manager called each member who was enrolled in the program and offered whether it be face-to-face care management, it could happen in the home, it could happen at McDonald's, it could happen at the doctor's office, at the park, it could happen anywhere, or telephonic care management as well. And if you look at our results, they're quite interesting. After a year, so fast forward till January of 2018, the opioid prescribing went down by over 55% in this cohort. The benzodiazepine use went down by over 30%. Gabapentin, which is a Schedule II medication in Kentucky, went down by a little over 20%. And then, which was interesting, is that Lipitor, a common cholesterol medication, actually went up. And the theory behind that is that the patients had better coordination of care, had somebody with whom they could see on a regular basis, and the compliance went up, which was an unexpected story. And this was all a little bit unexpected. We didn't realize the numbers would go down as much as they did. But this was our Medicaid population in Kentucky. And then similar, but a little bit different, for our Medicare population, between 2015 and 2017, we identified about 2,100 members that we thought were at risk for opioid use disorder. And we intervened. We had our pharmacists call these members, talk to them about alternative therapies, and we've heard about massage and acupuncture and physical therapy, talked about alternative medications as well. We outreached our prescribers, providing them the information that they needed to help their patients and our members. And finally, to go back to the care management side, if we identified a behavioral health issue, our behavioral health care managers got involved. And if you look at the cohort that was enrolled from 2015 to 2017, we had a reduction of about 43% of opioid utilization. So again, very proud of the work that our teams have done. And then finally, I want to talk a little bit about the future. And this information is actually probably in play in most places, but I thought I'd touch on it over the last minute or so. Prescription drug monitoring programs are important, and I know that most states have them. I think there's maybe one missing currently in the United States, and it gives our providers real-time data as to what medications patients are taking. And you think, why does a payer need access to a prescription drug monitoring program? Well, you think about it, if somebody's new to plan or if somebody's paying cash for medications, we're not going to have that data in our claim system, and we need that information in order to intervene as quickly as possible. Electronic prescribing is becoming more prevalent these days, but it helps decrease adverse drug events, makes prescribing more accurate and efficient, and with that, we see a decreased cost of care and improved outcomes, which is the most important. Education is important as well, to continue the education. So we absolutely support continuing medical education for doctors, for physician assistants, or nurse practitioners. The state of Maine mandates 3 credit hours every 2 years, and Kentucky has similar rules. And if you look at it from a beneficiary education standpoint, that's important as well. I think we'll all be surprised at times when one of our patients doesn't have a great understanding about the use and misuse of opioids. The CDC recently came out with some information, which, basic messages to our members or to our patients about how to take medications properly. So never share medications, never take someone else's medications, proper storage and proper disposal. These are all pretty basic messages that we can relay, but sometimes they can be pretty powerful if somebody doesn't understand exactly what to do with their medications. Telehealth, it's important. You can absolutely increase the scope of care from a behavioral health standpoint. For our patients out there that may have some issues with opioids. And then lastly, we all talked about the community side, but the village is really important, and we have to get our Narcotics Anonymous and our churches and our transportation vendors and our providers and everyone in the community to pitch in. And we're seeing that in southeastern Kentucky. There's a great story coming out of Whitesburg. Hopefully we'll see some good data in the next several years or so, but they've gotten the community to rally around their citizens that have opioid use disorder. So with that, I'm going to end, and my contact information is here. So thank you very much.
Okay. We do have some time for questions, so if you have any questions for our panel, please go to the center of the room where the microphone is located and state your name and where you're from and ask your question.
My name is Allie. I'm from an insurance company in Connecticut called Connecticut. My question is for Dr. Schaps. You mentioned how you brought those members down to one provider, one pharmacy. Can you just expand on that a little bit with how you went about encouraging that, enforcing that for members?
So they were, we have an edit in our system which allowed us to assign them to one pharmacy and one prescriber. However, there were some circumstances where we had to relax that edit. When we talked to our members, if they had, for instance, let's say they were seeing a specialist, and outside of oncology, we didn't enroll any members who were undergoing cancer treatment. But if they had a specialist, so for instance, a gastroenterologist who was dealing with a very complicated GI issue, we would add that prescriber. If a member, needed a medication filled emergently at a different pharmacy, we were able to override that as well. It took a lot of coordination between my pharmacy team, my customer service team as well. The customer service team probably has my picture on a dartboard somewhere because we had a lot of phone calls initially. But nonetheless, it was an edit, but my pharmacy director did a phenomenal job making sure that we enabled those members who were in the program to get the medications they needed. But as well, though, making sure that those the narcotics and and the like were controlled by one prescriber.
Hello, Michelle Johansson, Performer X. Watana asked a question from everyone, and thank you for all of your feedback and some of your innovative ideas. Specifically around what was the feedback that you got from your prescribers and from your pharmacy network And, did fax blasting work more than other activities? What did you find to be the most impactful, especially with regard to your providers?
I think it's really important to try on the front end to get the message out before you start, applying edits. So I recognize that those that were appreciative were ones that might have reviewed the fax or reviewed the letter, or that we maybe did a better job than others of having the right contact information and getting it out to a provider office or whatnot. So I think it's the feedback that we got was that it's helpful to know ahead of time, right? So I think that's kind of key there. But in terms of methods, I think pharmacies just very commonly fax is the preferred method that we hear through our network. And then with our provider group, because of the engagement that I mentioned, we tried to really leverage individuals to deliver that message where possible, because we're so engaged with them, and we have teams that are meeting with our group. So we did a lot of that in person, and I think providing the why along with what was very helpful, and we got good feedback there.
I guess a lot of that would be the answer, ditto. Really finding out what is the best method of talking to, we've got to have our pharmacies ready to talk about these messages, because they're going to be that face certainly to the member, but also at times talking to the provider. We have, whether it's a preferred pharmacy relationship, our pharmacy network, certainly making sure that they're part of that voice and part of that partnership in our local communities has been a focus, whether it's the upcoming edits for 2019 or prior activities that we've done around our opioid strategy and duplications of therapy, and really working to provide that safety message at point of sale. Additionally, working with our physician partners, in the relationships when we're out talking to them, whether in the community or with our different provider relations teams, really, again, getting that message out there, again, with the why, offering to be part of the solution, to partner, and giving them access to big data. I think at times, putting that information in front of them, recognizing how they look compared to their peers in terms of opioid prescribing is sometimes a great aha moment. And then that gives the avenue to start talking about how can we be partners in really working together with the opioid crisis and caring for our members and their patients. Also, we've had, obviously, all those in Medicare have had a lot of experience with the opioid case management, the retrospective programs that we've had, and having that opportunity when you're looking at a member that, while today we can't do that lock-in with a pharmacy or a physician, but when you're either blocking all opioids or blocking all but key opioids, we have a lot of opportunity to really talk with our physicians, and they're often very happy to have us as partners and, so to speak, at times be that bad guy in the background that's the one saying no, and helping to reinforce that message and help to drive change.
Okay, thank you for that answer. If we don't have any more questions in the in-person audience, we do have a few items we received from our webcast participants, and the first one is for Jacqueline, and it is, what is the nature of plan-sponsored wellness or care management plan that is the prerequisite to disease state-specific / clinically nuanced benefits and cost share reductions?
Yes, thank you. That's a really great question. We're currently still evaluating all the different ways that we will be able to incorporate existing care management programs, such as our Transitions of Care program, all of our special needs plan members who are in a SNP program management, as well as our chronic condition management and other short and long-term case management. We're also evaluating how we might be able to establish another type of wellness program that will allow us to handle higher volumes with more focused case management around the needs specific to opioid use disorder.
Thank you. And one more question for Jacqueline, and it is, how does Martins Point intend to communicate to beneficiaries about the disease state specifically / clinically nuanced benefits and cost share reductions?
That's another great question. There currently is not guidance from CMS about how we are supposed to communicate about these clinically nuanced benefits. So we're preparing a number of strategies as we await further guidance, whether that will be working with existing members in care management who already have these targeted disease states, or doing more specific outreach or broader communication to let people throughout our health plans know about this availability.
Thank you. And we do have just one more question, and it is for Annie. And it is, what have you learned after implementing the 12-week substance use coaching program?
We've learned a lot. We've definitely listened and tried to continue to evolve our program over time, where we felt like, based on the feedback we were receiving, we could, alter it a little bit, whether that was outreach efforts or, topics. We, discovered that it was really important to ask questions to allow our members to describe what they were feeling and what they thought about the different strategies or topics we were talking about, such as, what does over-medication look like to you, and some different ways that we hadn't approached the questions at the start. So I think over time we've gotten a little bit, smarter, I guess, in a way, but we've adapted our program to try to meet some of those, some of that feedback that we received.
Great, thank you so much, Annie. And I will just check to see one more time if we have any more in-person participants who would like to ask a question. Okay, well, seeing none, thank you, Jacqueline, Aaron, Annie, and Howard, for sharing how your health plan is working to combat the opioid crisis. Okay, if you would like to evaluate this session, go ahead and take out your phones to text your response, or go to the Poll EV link on your iPads, tablets, or computers and enter A. Okay, so now we are at our last session of the day, which is our open Q&A session. This means that all of our speakers from today are going to join us here on the stage. Each speaker will have 3 minutes to answer questions you have sent in throughout the day. Any questions that we do not have time to answer, we will get responses to those, and they will be posted on the CTEO event website at a later date. Okay, so to get us started, I would like to have our presenters from the Medicare Communications and Marketing Guidelines and Provider Directory Updates, Jeremy Willard and Christine Reinhardt, join me on the stage. So first, I'd like to just see if we have any in-person participants who would like to ask any questions of session 1. Remember to state your name and where you're from to ask your question.
Hi, Alicia Hightower with Avisis. We have a question about downstream entities in the call center hours. If we're not doing any enrollment activities, if they still apply, the 7 days a week.
Okay, just making sure that that's on. So it really depends on what activities they're doing. It's not so much enrollment, but if they're functioning in the customer service function, then the call center hours would apply. If they're doing things like telesales, then they would not apply as far as that section of the MCMG goes.
Hi, Deanna Vaslik, America Healthcare TOS. Just one question about the mailing statements on the envelopes. We've gotten rid of this is an advertisement statement. The one that now says important plan name information says it applies to marketing and communications, so we were interpreting that to mean that we should put important plan name information on marketing pieces as well. Is that correct?
No, actually, our intention is for that to be one kind of existing members. So when you're providing information, again, a lot of the things that would be covered under 100.4, not for any sort of just general marketing. So that used to be the advertisement disclaimer that we've done away with.
So it's only for current members?
Yes.
Okay, thank you.
Good afternoon. I'm going to ask a question that I did send in, but I just want to make sure that it gets addressed. So I wanted to know in section 70.1.1, there's language that says about the website, says that that plans and Part D sponsors must ensure that their website maintains separate and distinct sections for their Medicare information. And then it goes on in new language that says plans Part D sponsors may not include or market Medicare supplement content in their Medicare information section. My question is, does that solely apply to the marketing sections, or would that also apply to communications/education information, like learn about your Medicare options, learn about your health options? That plans, I'm sure, are trying to provide so people understand what they have available.
Yep, so a couple of different thoughts on that. I think I have seen plans that they kind of provide that more general website where it kind of helps a beneficiary to hone in on what they're interested in. And so it may say, learn about your Medicare options. I don't think of that as being the website that is required by CMS. So I would say, in that light, yes, that would be allowed to have various products, including Medicare supplemental plans. I think once it gets to the site that's required by CMS, then that provision would apply to both marketing and communication content on the website.
So you're thinking of that as two separate websites, like different URLs?
I don't know about different URLs. Just my experience in looking at websites, there's typically like a landing page that helps to direct the beneficiary to, whether it be commercial, whether it be Medicare, whether it be Medicare supplemental. That's where I have typically seen that sort of, questions to help direct them to the right source. I think when it comes to the Medicare website itself, that's where we don't want other supplemental information to be posted because it can cause beneficiary confusion.
Okay. All right. Thank you.
Yep, sure.
Okay. Thank you for that question. And if we don't have any more in-house questions, we will switch to a couple of questions that we did receive from our webcast participants. And one of them is, should we submit for review follow-up letters that may be sent to beneficiaries following a sales appointment? The letter may cover plan specifics, but doesn't fall into any of the categories of HPMS.
Can I see that? I'm sorry, it was a little difficult hearing. So it's asking about this letter that would be a follow-up to beneficiary
being sent a sales appointment. And as long as it doesn't provide content that would be considered marketing, and we think of that intent content definition of marketing, as long as that's not there, so we're not talking about benefits, we're not talking about cost sharing and things like that, then it would be considered a communication and would not require submission into HPMS for CMS review.
Okay.
Sorry.
Thank you. Okay, and then we have a few other questions. I think we have time for one more question, and it is, this person submitted. My question is, if a patient is enrolled in Part C Medicare Advantage and the patient decides to enroll in a Part D standalone drug plan, will that automatically disenroll the patient from his or her Part C coverage? And if yes, when will Part D coverage begin?
Yeah, this is more of an enrollment question, but if you're in an MAPD plan and then you enroll in a Part D standalone, it is going to disenroll you for the from the MAPD. And when it comes to when the Part D enrollment effective period is, I mean, it really depends upon when the enrollment application is in, what time frame you're in, whether you're in the AEP, if you have a special election. So that's really going to be beneficiary specific. And enrollment folks, if I got anything wrong, please let me know. But we're good. We get the thumbs up.
Okay, great. Thank you for that. And that concludes the time that we have for session 1. Thank you, Jeremy and Christine, for providing that additional insight. Okay, we are going to go ahead and go to session 3, best practices for clarifying grievances, appeals, and coverage requests. And those presenters include Stacy Page, Coretta Edmondson, Destiny Gordon, and Crescent Moore. To please join us on the stage. Okay, and as a reminder, for your in-house questions, please just state your name, where you're from, and let us know your question.
Thank you. I'm Heidi Harmon from Gorman Health Group, and this question is for Destiny and Crescent, and thank you for your wonderful presentation and insights. I'm wondering if Blue Cross Blue Shield of Tennessee anticipates any changes in policies and workflows of both the coverage determination teams and the organization determination teams with the advent of the new Part B step therapy.
At this time, just based off of the guidance that has come out, we're not anticipating any changes to our workflow because the turnaround times are still going to exist based off of what benefit it's going through. So if on the Part D side you're stepping through something on Part B or vice versa, you would have to adhere to those turnaround times. So we're really not anticipating any changes to processes.
We will go ahead and take a look at some of the questions we've received from webcast participants. And one of the questions is also for Crescent. We will go ahead and go there. And the question is the quality assurance team part of the grievance team, or is it a separate team?
So when we talk about our quality assurance process at Blue Cross, we actually don't have that pulled out as a separate team. So from a Part D perspective, we utilize our compliance team member who is embedded in our department to assist with those quality reviews. And then additionally, we have team members within the pharmacy CDA team who also do an additional set of quality reviews. So we don't pull it out as a separate team from a Part D perspective.
So from a Part C perspective, we actually have embedded quality review analysts that focus on all functions of the department. And we also have our compliance consultant that also does supplemental quality reviews as well.
Okay, thank you, Destiny. And we have another question for you that was from our webcast participants. And the question is, regarding your presentation, if a beneficiary is dissatisfied over a plan's decision to deny an organization determination, regardless of whatever inconvenience the member indicates the decision has caused them, would this really be handled as both an organization determination and a grievance? And it says there's some additional things. Though guidance, MOC, and CMS through guidance, MOC, and CMS audits, it has always been my understanding that the complaint would be handled as an appeal. A grievance would only be filed if they express dissatisfaction over something other than the decision itself, such as their provider not turning in medical records needed for review, misinformation, or the competency of utilization management staff.
That's a long one.
That is a long one. That's a mouthful.
So as noted in our presentation, you heard a couple of times about handling cases case by case and also listening to member perception. So in the scenario that I presented, that particular case had a denied dental surgery. The member did not like the fact that we did not cover it, and the member requested an additional service. So remember, there can be multiples associated with any request, and it is important to make sure that you dig into each case, case by case, to make sure to identify all different case types that could be present.
Okay, thank you so much. And I think we're going to have time to address one last question from our webcast participants. And this one is, why is coverage determination and organization determination used interchangeably for the initial determination? Were there regulations changed, or is coverage determination still the term for Part D and organization determination still the correct term for the first determination for Part C?
So no, there has not been a regulation change. So for Part D, you would still consider it a coverage determination, and for Part C, it's organization determination. I know internally we say that we use the term initial request or initial consideration, but the terms that exist in the current reg and in the current manual still stand for Part C and Part D.
Okay. Well, thank you so much to Stacy, Coretta, Destiny, and Crescent. You guys definitely got some tough and long questions today, so we appreciate your insight. Next slide, please. Okay, so if our next session, the Medicare Advantage and the Quality Payment Program, well, before I ask you to join, let's just see if we have any in-person questions for you guys, because we didn't receive any webcasts yet. I'll save you a trip on stage. Okay. Seeing none, we're going to go ahead and go to the next session. Okay, I'm not sure where my slide is, but our next session is going to be Meet the Center for Medicare Directors, and that's going to be several people joining me on stage. I know it's going to be Catherine Coleman, Amy Larrick, Jerry McCaughey, or Jen Smith, there we go, and then John Scott and Rebecca Paul. And Jennifer Shapiro for Rebecca Paul. Amy Larrick. Thank you. Okay. And again, if you have any questions, please step forward and state your name and where you're from.
Okay.
We'll go
Hi,
ahead and
Michelle
get started.
Johansson, Performer X. This question's for you, John. And actually, it's point of order. First, I just want to say that having been through many CMS program audits over the past 10 years, that the program audit staff is very professional and that the process has gotten really smooth, and you have a set of auditors, especially on the CDAG and formulary admin side, that truly understand the systems that they're auditing. So I know that that's a lot of hard work, and I wanted to say thank you for that. To that point, we really love the best practice and common conditions memo from 2014. Is there any possibility that another one would be released or something similar?
Actually, it's a good question. We haven't really talked about that, but I thank you for raising it, and thanks for the feedback. Really appreciate it, Michelle. And I'll go back to the team and we'll talk about it. Whether or not, I mean, it's good to hear that it was useful. I think, honestly, going forward, whether we make changes to the process now that I'm here and different from Jerry, and I wish I could take credit for what Jerry and Vicki did in terms of CDAG and ODAG teams before. I can't, but and Jen. They did a great job. I'm glad I got to inherit that. But we'll continue to move forward, and I think that's a good idea to consider moving forward.
Thank you very much.
Okay, any other questions from our in-house participants? Okay, well, we did receive one question from the webcast participants, and this question is, when will Chapter 9-21 compliance guidance be updated? And when will Part C, Chapter 13 be updated?
So for 9 and 21, we're working on it. I know. I'm also inheriting that one too. So we are working on it. I can't say honestly how close we are, but I know our team is reviewing it now. And then of course we have whatever changes we're making to it. We have the internal clearance process that we haven't started yet. But I'm hopeful that we will be able to wrap that up in fairly short order. But I don't have an ETA on that.
So for 13, it is in probably, I would say, middle to final stages of clearance. So we hope to have it out shortly for another round of public comment.
Okay. 2 questions? Oh, okay, sure.
So I got 2 questions as we were standing down here after our presentation that I wasn't able to answer, and said I would come back with the answers. So one was, how will Plan Finder show whether or not plans are expecting to to implement step therapy for Part B drugs in 2019? And the answer is, Plan Finder will contain links to plan websites, as it always has, where the annual notice of change and the evidence of coverage are required to be posted. So that information will be available to beneficiaries on plan websites in those 2 documents. And the second question was, how do we reach the policy division within the Medicare Advantage policy group? And that is a very long web link, but I will try to read it slowly and clearly, and then we can post it.
Sure.
It's https:// D as in dog, P as in Paul, A as in apple, P as in Paul, .l, M as in Mary, I.org, / and then DPAP mailbox, all one word, /.
Okay. Any more in-person questions before we move on? Okay. Well, thank you so much, Catherine, Jennifer, Jen, John, and Rebecca. Okay. And we did not currently receive any questions for our next session for tackling the opioid crisis in Medicare Advantage and Part D for our webcast participants. So before I ask those presenters to come on stage, I did want to see if we have any members of our audience who have any questions for this session. Going once, going twice. All right, no takers. Okay, so one last time, please go ahead and take out your phones to text your response, to go to the Poll EV link and respond to questions about our open Q&A session. And again, we thank all of our speakers for coming back and participating in our open Q&A session and providing some additional information. Okay. Well, that about wraps things up for us today. So please stay with me for just a few more minutes. I just have a couple of closing remarks. First, this conference will provide participants with the opportunity to earn CCB CEUs. To obtain your CCB CEUs, you need to complete the CMS attendance survey, which is found in the participant survey instructions posted on the CTEO website. The survey must be submitted by September 24th in order to obtain credits for your CCB CEUs. Again, CMS would like to thank all of the presenters today for your time and dedication to this, our program, and of course the in-house and webcast participants for your participation. All right. And if you would like to evaluate today's conference, go ahead and enter A in response to the question, I would like to complete the event survey. Click on the link that is presented to complete the survey. If you did not participate in polling today, but would like to provide your feedback regarding today's events, a link to the event survey will be emailed to you, or you can connect to the survey using the QR code with your smartphone or tablet located on the card on the table or the participant survey instructions. Please consider taking a few moments to provide CMS with your feedback. Again, thank you and have a wonderful evening.